We'll call the meeting to order, and if you'll join me in the Pledge of Allegiance.
I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
Dee, could you call the roll, please?
Director Nicholson.
Present.
Director Stewart.
Present.
Director Wallace.
Present.
Director Danielson.
Present.
Director Eben.
Present.
Thank you. Nancy, we have two education sessions. If you could introduce the first one on community needs assessment.
Yes, every 3 years we do a community needs assessment in conjunction with the Hospital Council of Northern California. Tina Nunez is here this evening to present the results of their study. She currently serves as the Associate Administrator of Ambulatory Care at our hospital. In this role, she oversees a number of areas, including medical imaging, laboratory, the Women's Center, respiratory, wound care, the rehab departments, which include PT, OT, and speech, and community relations, community outreach, and the Development Corporation. She's been at Washington Hospital for 20 years and has held various roles of progressive responsibility during that time. She received her undergraduate degree from the University of California at San Diego, and she completed her master's in public health at UCLA. With that, I'll turn the meeting over to Tina.
Thank you, Nancy, and thank you to the board for having me this evening. So tonight, as Nancy said, I'm going to present the 2016 Community Needs Assessment. So a little bit of background. The Affordable Care Act was enacted by Congress in 2010, and as part of that act, it stipulated that tax-exempt hospitals must conduct a community health needs assessment every 3 years. The guidelines require that nonprofit hospitals adopt an implementation strategy plan of the health needs that are identified. This was the second assessment since the ACA was enacted. Now, even though it was a requirement as of 2010, as a district hospital, we were exempt from the legislation requiring this prior to ACA. But being a district hospital, we felt it was very important to participate in the community needs assessment, and we've been doing it for over 20 years in terms of developing programs and services. Programs such as the Health Insurance Information Service, we have our community mammogram program, and as recently our low-dose CT screening program have come out of the community needs assessment. So first, a little bit on the process and methodology. So both quantitative and qualitative data were gathered during the process. I'm sorry. Sorry. So both quantitative and qualitative data were gathered during this process. Washington Hospital collaborated with 11 local hospitals and worked with a company called Applied Survey Research in order to gather the information. In terms of quantitative data, as always, data is several years behind when we're doing this. Quantitative data was collected through various reports, including the Alameda County Public Health Department, the California Cancer Registry, the California Department of Public Health, and OSHPD. Also, as part of this process, we did a qualitative data collection, and this was conducted through several focus groups. We had focus groups with professionals, we had focus groups with residents, and we had key one-on-one interviews. And it spanned a number of topics, including aging and family services, emergency services, low income, mental health, and women's health, just to name a few. So to start with, in terms of the district, for Washington Hospital, the primary service area is defined by voting precincts. So our district, as you are very well aware of, is Fremont, Newark, Union City, unincorporated Snow, and Hayward. For Hayward, it's the two southernmost zip codes of Hayward, 94544 and 94545. But 94545 is a golf course and there's no residential homes on it. So for purposes of this report, 94544 is used. The other thing to note through this report is unincorporated Sunol has a very small population. It's less than 1,000 people. So just keep in mind that relatively minor differences in numbers through this report can appear larger, and you're going to see that in the slides that come up. So to start with, the Tri-City population has been growing over the years. The Tri-City population was 352,995 people in 2015. This is an increase of approximately 15,000 since 2013. In terms of race and ethnicity, the district has a very diverse population. The Asian population is the highest ethnicity at 44%. Now, the Asian population includes Indian, Asian, Filipino, Chinese, and Japanese, so just keep that in mind when we say that Asian. White is the second highest ethnicity at 30.8%, and the next is Latino of any race at 23.3%. So when we break that down into the Tri-City area, so for the ethnicity breakdown by city, Fremont has 52.2% of Fremont are Asian, which is a slight increase from a year ago. White is the second highest ethnicity at 29.3%, which is a slight decrease from the year prior that we were reporting on. And next is Latino of any race at 14.1%. In terms of Newark, 37.9% of Newark are white, which is a decrease from the year prior. Second highest ethnicity is Latino of any race at 33.1%. Again, a slight decrease from the year prior. And next is Asian at 29.5%, which is a slight increase from the year prior. And in terms of Union City, 51.8% of Union City are Asian. Second highest ethnicity is Latino of any race at 22%, and next is white at 21.2%. In terms of the age of the population, so the next three slides are going to show Fremont, Newark, and Union City. So for Fremont, 36.7% of the residents are between 20 to 44 years of age, with the median age of 37.4. For Newark, 36% of the residents are between 20 and 44 years of age, with the median age of 38.2. And for Union City, 37.8% of the residents are between 20 and 44 years of age, with the median age of 37.1. So in terms of the uninsured, the percentage of uninsured slightly dropped across the board from the previous report, with the exception of Sunol, which remained the same at 4.5%. And I think since the 2014, we've seen this number decrease. In terms of life expectancy for most cities, it increased slightly from 2010. The overall life expectancy compares favorably with the national level in Fremont, Union City, Newark, and Hayward. Sunol was just under at age 78.6. Death from all causes in Fremont, Newark, and Union City rates were lower than the county and state. Hayward was not significantly higher. The highest rate is found in Sunol, and it should be noted again that small communities such as Sunol does have the rates vary a little bit. So out of this, seven health needs were identified. We have asthma, behavioral health, cancer, cardiovascular disease, stroke, maternal and child health, obesity, diabetes, healthy living and active living, and violence and injury prevention. So we're going to go ahead and go into each of those. So the first being asthma. This slide is showing the asthma emergency department visit rate across the state, county, and cities. The rates are per 10,000 population. The top two bars shows the state and county asthma emergency department visit rate at 49.9 and 76.9 respectively. Fremont had a notably lower asthma emergency department visit rate at 39.3, and Newark and Union City and Sunol had higher emergency department visit rates compared to the state average. In terms of asthma prevalence, the proportion of adults with asthma was higher in Newark than in Fremont and Union City. Newark is at 16.1%, Fremont at 15.6%, and Union City at 15.2%. All cities had higher adult with asthma compared to the county and state. Data was not available for Sunol as the numbers were too small. So in terms of this slide, it's showing asthma prevalence in children and teens. There were more children and teens in Fremont and Union City that had asthma than in the county and the state. And again, for this slide, Newark and Sunol, there was no data available. So in terms of through the community input through the one-on-ones and the focus groups that were conducted, the community expressed concern about childhood asthma. Residents said asthma is a bigger deal in elementary schools. And the other thing was, depending on the time of the year, according to residents, there can be a high number of pediatric respiratory issues. So those are some of the things that came out of the focus groups. So in terms of what Washington Hospital offers in terms of programs, although current programs are predominantly adult-focused, we are exploring means to address childhood asthma. Some of the services that are currently offered are our pulmonary rehab program, which is the one-on-one counseling and support services. We offer the Better Breathers, which is a very active support group here in the community. And also we do a number of education and screenings throughout the year for the public that are free to the community. So the next is behavioral health. So the rate of emergency department visits for mental health illness problems was much higher in Alameda County than the state. It was also high in the cities of Newark, Union City, and Sonoma. Self-inflicted injury emergency department visit rates was lower in Alameda County than the state, and it was also lower in the cities of Fremont, Newark, Union City, and Sonoma when compared to the county and state. The emergency department visit rate for substance use was higher in both Alameda County and the city of Sonoma than the state. Fremont, Newark, and Union City were all below the state average. In terms of intentional self-harm, the death rate due to suicide was lower in Fremont, Newark, Union City, and Alameda County than the state, but much higher in Sonoma. So in terms of the focus groups and what was heard through the focus groups and the one-on-one interviews, the community members felt there is a lack of mental health providers. Residents reported a lack of information as to where and who to speak with to obtain those services. Community members have expressed poor discharge procedures and lack of follow-up after mental health emergencies. Participants said there was a lack of placement care and behavioral health services for adolescents, and residents reported that a lot of mental health providers do not accept their insurance. In terms of, there are a number of efforts that the hospital is taking to address this health need. I think most notably, Nancy, I think you've heard that has begun preliminary discussions with Alameda Health Systems to explore a possible collaboration to increase access to mental health services here in the South County. Part of this effort was developing a matrix highlighting really the lack of services that are here in the South County. Other efforts include crisis counselors in the emergency department and also community education through our health and wellness. Most recently, we did do a health and wellness program on understanding mental health disorders with Dr. Seema Siegel, and it was very well attended, and we are now in the process of developing an educational series on mental health disorders for the community. So the next area is cancer. So cancer is the second most common cause of death in the United States and in California. For the cancer health needs, the report provided cancer case counts by city. The count is the number of new incidences for that year, and it is not age adjusted. So the count for Fremont is 717, and of course it's higher than the other cities because Fremont has a higher population. This was slightly up from the prior reporting period. Newark and Hayward counts were slightly higher for 2013 than the prior year. So now we're going to break it down in terms of breast cancer. The incident count of breast cancer in Fremont was 131, a little lower than the prior year. Newark and Hayward were slightly higher counts than the prior year. So for cervical cancer, the incident count for cervical cancer in 2013 in Fremont was 8. The others were too small to have a reporting statistic. In terms of colorectal cancer, the incident count for colorectal cancer in Fremont was 58, a slight decrease from the prior year. The incident count increased for Newark and Union City from the prior year. In terms of lung cancer in Fremont, it was 75, same as prior year. Newark, Union City, and Hayward all slightly decreased from the prior year. The incident count for prostate cancer in Fremont was 90, a decrease from the prior year. Newark, Union City, and Hayward all increased from the prior year. So in terms of the quantitative community input, community comments mainly focused on the transportation issues and the difficulty in getting to and from treatment. That's the main thing that came out of the focus groups. So Washington Hospital has a number of programs. It's very extensive in terms of the range of cancer programs and services. I think most notably recently with the opening of the UCSF Washington Cancer Center, which is a strategic affiliation that provides district residents with local access to essentially the latest technology and care. Other programs include the Infusion Center, the lymphedema services, and education, just to name a few. And of course, we do a variety of screenings as well for the community free. The hospital offers a number of support services, including support groups, and we have nurse navigation in addition to community education. Washington Hospital receives several accreditations and awards related to cancer, including the American College of Surgeons Commission on Cancer Outstanding Achievement Award. It should be noted that Washington Hospital was one of 2 hospitals to have earned this distinction 3 surveys in a row. So it's a really good accommodation. So the next is cardiovascular disease and stroke. The next health needs focus really on heart disease is the primary leading cause of death in the United States, and stroke is the 3rd leading cause of death in the United States. So in terms of heart disease prevalence, in Fremont, Newark, and Union City and the county, they were lower than the state. Data was not available for Sonoma. In terms of coronary heart disease hospitalization rates, in Newark, Union City, and Sonoma, they were higher than the county and state averages. However, Fremont hospitalization rate was just below the county. Overall, there was an increase in heart disease hospitalization rate from the previous reporting period. Deaths due to coronary heart disease, which was much higher in California than the Healthy People 2020 objective. So just to note, the Healthy People 2020 is a set of goals and objectives with 10-year targets designed by the Department of Health and Human Services. So that's what that indicator is related to. Fremont, Newark, and Union City and Sonoma all increased from the prior reporting period and were higher than the Healthy People 2020 goal. In terms of congestive heart failure hospitalization rates, Union City had a very high rate. Fremont, Newark, and Sonoma were below the county average. In terms of stroke hospitalization rate, Union City's stroke hospitalization rate was higher than the state and the county. And data was not available for Sonoma. So in terms of the community input through the focus groups, residents said that in specific geographic areas, there are few to no supermarkets or farmer market offering healthy foods, and there is a lack of access to open space for exercise. Key professionals noted that they are seeing an increase in the number of Afghani and Indian residents with cardiac problems, and that there are a lot of multiple diagnoses. And key professionals noted Latinos and Blacks tend to have a higher level of hypertension and other risk factors. So in terms of Washington Hospital, we offer a number of cardiac services, including cardiac rehab, mended hearts, and community education. And of course, we are a cardiac receiving center as well here at Washington Hospital. In terms of stroke services, we are certified as a primary stroke center by the Joint Commission and designated as a receiving center for strokes here in Alameda County. We also offer a number of support groups and screenings, and we do provide community education throughout the year. So Washington Hospital, as I said, received several accreditations and awards relating to heart health and stroke prevention. Most notably, the Joint Commission granted Washington Hospital full recertification of its Advanced Primary Stroke Program. The hospital received no recommendations for improvement, which is the highest outcome possible for recertification. We also were awarded awards from the American Heart Association and from Healthgrades. So the next area is maternal and child health. So the percentage of families living below the federal poverty level in the county and district cities were lower than the state. Other Alameda County indicators were identified. In 2014, 14.9% of the population in Alameda County reported experiencing food insecurity at some point during the year. Infant mortality, low birth weight, and prenatal care in Alameda County were better than or similar to the state averages and the Healthy People 2020 objectives. In terms of the community input, residents reported they felt sexual health education and general healthy decision-making for teens was lacking. So in terms of maternal and child health and the services that we offer, you can see on this slide that we offer a number of services. To address food insecurities, the hospital coordinates with Alameda County Food Bank and CalFresh programs to ensure that low-income families have access to healthy, fresh foods by donating 400 to 600 pounds of food each year. The hospital also donated funds to Tri-City Volunteer Food Bank and Thrift Store towards the purchase of a mobile food pantry to increase access to healthy food to underserved communities. Another item to note is Washington Hospital will be soon opening the prenatal diagnostic clinic as well. So the next section is obesity, diabetes, healthy living, and active living. Union City had a very high diabetes hospitalization rate compared to the state. Newark had a high rate compared to the county and state. And Fremont and Sonoma were below the county and state. In terms of diabetes-related indicators, this slide is showing the percent of children grade 5, 7, and 9 within the obese body composition category. Youth obesity was alarmingly high in Union City and Newark, above the state and the county. The percent of children in Alameda County who are physically inactive was slightly higher than the state, and all cities were below the county and state averages. Food insecurity was also identified as an indicator in Alameda County, with 14.9% of the population experiencing food insecurity, which is higher than the state. Alameda County has a higher density of fast food restaurants as well, which was noted. And according to the U.S. Department of Agriculture, food insecurity is associated with chronic health problems in adults, including diabetes, heart disease, high blood pressure, obesity, and mental health issues, including major depression. So in terms of the community input, we heard that community members complained of a lack of access to healthy foods. The community felt it was expensive to eat healthy. Residents were experiencing food insecurities, and families are stretching 1 week's worth of food to 3 weeks, trying to. Community members said there was a lack of affordable sports and recreational activities for youth and adults. And the community believed that culturally familiar food is unhealthy. Eating healthy isn't always a top priority for new immigrants. Eating food that is familiar to them provides comfort. And residents said health providers do not give culturally specific nutrition recommendations. As previously mentioned, the hospital coordinates with the Alameda County Food Bank, CalFresh, and Tri-City Volunteer Food Bank. To meet the needs of diabetes, the Hospital Outpatient Diabetes Center offers a variety of programs, including individual and group classes, a monthly education series known as Diabetes Matters, and they also provide a support group. And during the summer months, Washington on Wheels Mobile Health Clinic provides free glucose screenings throughout the district. Additionally, the hospital offers a number of free health and wellness seminars, including prevention and treatment of diabetes. And then, of course, we air everything on our InHealth television station, and we also have it on our website. So the next section is violence and injury prevention. So the unintentional injury emergency department visit rates in all cities in Alameda County were below the Healthy People 2020 objective. The death rate due to homicide was higher in Newark and Alameda County than the state and the Healthy People 2020 objective. The death rate for pedestrians killed by motor vehicles was much higher in Union City than the county, state, and the Healthy People 2020 objective. Residents worried about being attacked when they walked along the streets. So here are some of the things that we heard from the focus groups and the one-on-one interviews. Residents worried about being attacked when they walked along the streets. Community members felt there's a lack of empathy from healthcare and law enforcement towards victims. Regarding domestic violence, community members reported a lack of effective screening for domestic violence victims. Often, domestic violence victims are prevented by their abuser from having a primary care provider. Poor communication or lack of connection between health clinics and domestic violence organizations for referrals, and there are not enough providers and facilities for domestic violence victims. Here's a list of the items that hospital is currently doing to address this need. To highlight just a few of them, we've established a relationship with SAVE, Safe Alternatives to Violent Environments. We also, the hospital's worked with the City of Fremont to make improvements to enhance the pedestrian safety at the Civic Center Drive crosswalk. And most recently, Washington Sports Medicine acquired the iSync cognitive assessment tool to test for concussion or other cognitive impairments. So next steps on the community needs assessment. Today was really about presenting the data to the board. The next step is to develop a 3-year implementation plan to address the identified health needs, which will come ultimately to the board in a future board meeting. So I'm happy to answer any questions. I know it was a lot of data.
I have a couple of questions. In regards to all of the things that related to the youth and children, is this information going to be shared with the school districts?
Yeah, we can do that. It will definitely be shared with the, of course it will be published on our website, so the whole community will have access to it. And then we will be developing, as part of our implementation plan, we'll be developing programs and services, and part of that may include working with the school system. Okay, good. And also the cities, because I know this is a touchy issue, but with all of the construction and housing that's going up, it seems like the only place that the youth have to go to for recreation is maybe to walk around the mall. Everywhere that they were going is getting eliminated. So is this going to be shared with the cities as well? Yeah.
Okay.
We can look at doing that.
Okay. Thank you.
Thank you, Pat. Any other questions? No, I agree with Pat that, to me, the most alarming data that you presented was the high rate of childhood obesity, because we know that children who are obese will continue that in adulthood, and that is a significant risk factor for the development of diabetes, hypertension, coronary disease, and stroke. So it may not have immediate impact on their health when they're young, but we will certainly see that in the decades ahead. And I agree that we need to have more opportunities for the youth to exercise more, be active more. Less screen time is probably the most important factor there, and to try to engender a culture within the youth of being more active physically, and that will require facilities and opportunities and people to coach them in all the different activities. So I think we've got a lot of work ahead of us here.
Yeah.
Thank you.
Our next program is about our new grad training program. And here to make that presentation is Sam Avila. She's been with our hospital now for 25 years. It's a long time. And she's a registered nurse with a master's degree in nursing with a focus on leadership in healthcare organizations. She's currently the director of Med-Surg Education and Staff Development, and also the new grad program coordinator. She started here as a new grad RN on 4 West, and then worked as a nurse manager for many years on various units. She's had oversight for the RN new grad program for approximately 15 years. Turn it over to Sam.
Before Sam does her presentation, I just wanted to say a little bit about Nurses Week. As we celebrate Nurses Week at Washington Hospital, I would like to take a moment to express my thanks to nurses at all levels of the organization for their extraordinary energy exceptional efforts, outstanding professionalism, and dedication to our patients every day. I would also like to thank our CEO, Nancy Faber, and our Board of Directors for their unwavering support of our nurses and their commitment to creating a work environment that enable our nurses in delivering the highest safety and quality to our patients and community. And again, I want to say Happy Nurses Week and also Happy Hospital Week. Thank you. And now here's Sam.
Thank you for the opportunity to come and talk tonight. Yep. Please excuse my voice. I'm a little bit hoarse, so I'm not as high-pitched as usual. So I apologize for that. I'm very honored to come and talk to you tonight, to present to the board and to talk about one of my passions in nursing, excuse me, which is a new grad program. I'm very fortunate to have started here, as Nancy mentioned, 25 years ago. Wow, hard to believe. As a new grad. Thank goodness, and to Alice Santos sitting over there, she actually is the one who hired me and has kept pushing me along in these last 25 years to do new and better things for our organization. So first of all, again, as Stephanie mentioned, is we want to thank you for allowing us to celebrate Nurses Week. We were able to do this and have a presentation. Oh, thank you so much. We're able to celebrate Nurses Week every year. We bring our nurses together. The last few years we have a tea, and we'll be having another tea on Friday, so all of you are welcome to attend. It's always a fun event. The nurses get very excited. They come down. Our F&S department does an awesome job of decorating and providing a really nice environment for us to celebrate our week. This year, as per our American Nurses Association, the theme is nursing the balance of mind, body, and spirit. It acknowledges that the self-care of the nurse is just as important as caring for our patient. If we don't keep ourselves healthy in mind, body, and spirit, then it's hard to keep our patients healthy and our community healthy. Part of that includes physical activity, nutrition, rest, quality of life, and of course, safety. One of our roles as a nurse, which as you know, we have many, you always hear the nurse as a patient advocate or as an advocate, but we're not just a patient advocate, we also need to be our own health advocate. So according to the American Nurses Association, a healthy nurse actively focuses on creating and maintaining a balance and synergy of physical, intellectual, emotional, social, spiritual, personal, and professional well-being. As the nurse can promote that within their professional role, they, again, can promote that health of the patient and health of the community. The nursing is one of the largest and most trusted healthcare professions within our nation's healthcare system. And it's hard. You know, it's not easy to be a nurse. It's not easy to be in any of our positions here in healthcare, but nursing is rough. And every day we're faced on managing very complex patients and doing this and trying to care for ourselves as well. And it's not just one patient, it's 3 or 4 or 5 or 6 or 7, or in the ER, maybe 10 a day. There's so many that we have to help. As a magnet facility, we help to create that positive working environment, positive culture and working together and teamwork, mentoring, just really working together. Also, as part of our health and wellness here at Washington Hospital, we have several things in place. We have our workplace safety program, lifting equipment, the lift team, encouraging the teamwork on the unit when we're going to move patients, and just working together with our rapid response team even could fit into that. Our F&S department, again, does a great job at providing those healthy options. So if they do go down to the cafeteria, we have the option of a balanced diet. We have a 24/7 meditation room, and we have massage therapy available. We have annual education through SABA on workplace safety, and we have our annual health and safety fair. Part of our healthy nurse advocate is that professional well-being and professional growth. We have our shared governance model here. Probably all of you have heard of that. We have 6 councils within our shared governance. And pretty much anything and everything that affects our nursing practice here at Washington Hospital goes through shared governance. So our nurses at the bedside truly have an impact on their practice here, which is amazing. It's such a great process. It's very robust. I have a pleasure of being on the coordinating council and supporting the rest. One example of how we support our well-being is that came through our PEC council. We have a professional engagement council. That's pretty cool. So talk about supporting our professional practice. We have a whole council dedicated to professional practice at Washington Hospital. And what came out of that last year was a job shadow program. So our nurses have an opportunity to use an ed day or come in on their time off and shadow another nurse. So if they want to see, for example, sometimes the procedural areas are a little bit of a mystery. I'm med-surg. So when I go down to the cath lab, I really don't know what happens in the cath lab. I know that they have some sort of cardiac procedure. I know that they come up with a sheath or I have to watch their groin. But what really happens down there, I have no idea. So what it gives the nurse an opportunity to do is to go down there and shadow, for example, a cath lab nurse, or go down to the OR and see a procedure. Or maybe I think I want to be in the ER long term and I'm a new grad. I can go down and shadow an ER nurse and see if this is really where I want to go and where I want to grow to be. So it's a great opportunity. We've had a really positive response. And it just gives them an opportunity to see what else is out there. They can shadow anybody in the hospital, case manager, quality. They could shadow me if they want to. We also have lots of education offered. We have last year and this year again at our Nurse Week, an education fair. So we really promote that additional learning and education. So if they want to go back to school and get their bachelor's or their master's, want to take continuing education classes, we're providing them that information to do so. We also provide lots of educational opportunities. We really encourage them to go to professional conferences. We provide additional seminars. We provide on-unit education. We have a monthly charge nurse education focusing on the topics that they really need to know. And those topics are actually coming from them. I did a survey last year of the charge nurses to see what they want to learn. And that's what our topics are focused on. Okay, so now about the really fun part of my job. Also stressful a little bit sometimes, but the fun part of my job is the new grad program. Over 20 years ago, so that would be me in 1992, we had our first formalized new grad program as a cohort. I was very fortunate to be selected as part of that group. At the time, I can't remember exactly how many we had, maybe about 15, and there's still 2 of us remaining. So that's pretty neat. After that, we kind of went into a period where we hired new grads individually on the different units. And then a little bit later on, we brought back the formalized program. What we found with that formalized program is it really helps, and the literature really supports this, and our numbers, our data supports this, is a formalized program, bring them in as a cohort where they have that peer support. They have someone monitoring them. They have someone teaching them. Really helps to ease their transition to practice tremendously. It helps to ease that enculturation into Washington Hospital. Really helps to emphasize the patient first ethic. Really helps to emphasize our professional practice model. We get to teach them right from the beginning how we want them to be a professional nurse and allow them to grow. It also helps, of course, to help with our staffing. So one of the main reasons to do it, of course, is to help with our staffing. It also helps not only Washington Hospital, but it helps our local schools of nursing. We hire our new grads actually from all over. It's not solely the Bay Area. We do hire sometimes from out of state or from Southern California. But the majority of our new grads actually come from local schools. So Cal City Bay, Samuel Merritt, San Jose State, San Francisco State, UCSF, USF. Those are all the schools that kind of are dominating if we look at our track record of who we hire from. But again, sometimes we do hire from out of the area, and a lot of times those are students that their family's here, and they went somewhere for school. They decided to venture to University of Hawaii, but wanted to come back, or decided to go down to Southern California, but want to come back to the Bay Area where their family is. So that's not uncommon. Again, we couldn't do the program without the support of Nancy and Stephanie, so thank you very much for allowing us to continue to have the program and allowing me to continue to run it. With that, I also have to say that I don't think you'll find another hospital out there that has such a direct tie to the chief nursing officer to the new grad program. This program is a direct report to Stephanie and has been for years. You're not going to find that anywhere else. She really helps to influence the program and what goes on. We do get a lot of applications. On average, it's at least 300 per program. At least 70% of those are bachelor's or higher. It's not in the slide, but I'm going to just personally, because I review every application. So at least 70% are bachelor's or master's prepared. It's highly competitive. Once they are screened through that 300, they have to go through 3 rounds of interviews, with that final round being with Stephanie to help us make that final selection process. Again, you won't find that anywhere else. They're all full-time benefited positions, and they all go into our med-surg areas to begin with, because we really believe that med-surg is that foundation, and then they can grow from there to wherever they want to be as a professional nurse. The program itself is a combination of classroom and one-on-one preceptorship with an experienced nurse. They usually start out on days and evenings, and then they will transition to other shifts throughout the program depending on how they're doing. They will start out on any one of our med-surg units, and they do get an opportunity to work on the other units as well during the program. So they might start out on 5 West and then flip to 3 West, or start out on 3 West and flip to 5 West. But they get an opportunity to see those other units, so when they float or when they go to transition out. Contents of the classroom, this is just a really small list. We cover a lot with our new grads. So we talk about right up front our mission and our vision and our patient first ethic. We talk about our Washington Hospital professional practice model throughout the program. We've integrated just recently with the integration of team steps into the other areas. We've integrated team steps into the program. Medication is always, of course, a hot topic. We spend a lot of time on medication safety, and Rayhan, our medication safety officer, also comes towards the end to talk about medication errors and things that they're seeing on the units, so we can help support that process. Of course, patient experience, because that's number one. That's, again, an ongoing thing. We do case study review throughout the program. We talk about not only developed case studies, but what they're seeing on the unit. So what type of difficult, I'll kind of ask, well, what are you seeing on the units? Tell me about a difficult patient that you've seen. Tell me about a rapid response that you've had. Tell me if anybody's had a code blue. And then we'll talk about what they saw and what they did and kind of debrief those incidents so everybody can learn from those. Additional areas as needed and requested, we put that in there because the program changes from program to program. I can't say there's ever been one new grad program that's exactly the same as one before it. And that's because we're constantly looking at continuous improvement. We do that with the new grad program. We get feedback from our nurse managers, from our preceptors, our charge nurses, from Stephanie. We look at new service lines that might be coming in. What do they need to know? Not what other hospitals are doing. It has nothing to do with other hospitals. It has to do with what do they need to know as a new nurse here at Washington Hospital. So we're constantly re-looking at the content and changing the format to best accommodate. Sometimes we do it to accommodate the group. Maybe the group just needs more information on something. It depends. An example, I've already recruited Dr. Achanta for the next program. He's smiling. To come and talk about post-op care. He did a great presentation for us for Med-Surg last year, so he's going to be on my calendar to present to the new grads and to Med-Surg again, because it's such an important area. And whether you work on 3 West or you work on 6 West, the same principles apply. And of course, ongoing clinical follow-up and evaluation, not only by the preceptors, but by the charge nurses, the staff nurse 3s and 4s, and then I make at least weekly rounds with all of them. So, why is this all so important and why am I so excited? Because we have great outcomes. We really do. Approximately 3 out of 4 new grads choose to stay at Washington Hospital in that first year. So if you look at new grad data and retention rate, the average turnover rate or retention rate for new grads is about 70% on a national average. So about 30% of new grads are leaving that organization within the first year to go and do other things. And some of them leave nursing altogether because they decide that just isn't their cup of tea. Here we have a 93% retention rate. And some programs we have 100%. So we have the occasional one who will leave for different reasons, maybe going back to school or decide to do something else, but for the most part they choose to stay. Also, and this isn't in the slide, but I went back and looked. So since 2003, because that's when I really started tracking the data, we've hired about 200 new grads. That's a lot. And we have, again, not official, but about a 70% retention rate of those 200. That's pretty amazing. We have new grads that kind of ties into that. So they're not, those 200 aren't all in med-surg. They're everywhere throughout the organization. It's so exciting for me to walk through the hospital on a daily basis and say, oh, that was a former new grad. Oh, that was a new grad. Oh, that was a new grad. Oh, that's a new grad. Oh, yeah, there's another one. And I see them and I say hi to them, not only as a nurse manager, but I know that they were in the program. And oftentimes they come and remind me. I had one of our float pool nurses, I was in my office, came and knocked on my door, and she just kind of came up and gave me a big hug, and I'm like, oh, okay, great, I get a hug. And then she told me after that it was her 6-year anniversary on that day for being a new grad. So she wanted to come and find me and tell me that it was her 6-year anniversary and give me a hug. And she's still in our float pool. So that type of stuff is very exciting. Again, currently about 96% of our new grads do have bachelor's degrees or master's, and that small percentage that don't, they're working on it. Because we tell them when we hire them, if you're not associate degree, it's an expectation that they will go back to school. So the few that are not are currently in bachelor's BSN programs. Again, kind of the so what, the outcome, we have many of our nurse leaders that were former new grads. So we have Alex O'Brien on 5 West, our current nurse manager, Jimmy Chang, our current nurse manager of 4 West, Karina Nagor, who was on 4 West and is now one of our nursing supervisors, Michael Platzbecker was a new grad, Kristen Ferguson, Kristen, yay. And Denise Fasolis, one of our most recent additions to our management team, who is over our IJRR clinic. And Denise actually came in through a special program we did with Aloni a long time ago as a student nurse and became a new grad and then progressed and went into EPIC. 3 out of our 4 nurses of the year for last year were new grads. Again, okay, so this is why I get so excited, because I get to see how they grow and they're progressing and they're doing all these fun things in the organization and they're helping us. Janelle Kelly, our nursing supervisor. Katie Gorman, who is a relief charge nurse. She does a lot of precepting for me, and she's recently become a BLS instructor. Yvonne Eugenia Crum, one of our staff nurse 3s and main charge nurses on 4 West, was also a former new grad. Okay, so this is just a small sampling. Not all the 200 of them. We couldn't possibly get them all on the slides, or I couldn't run around and take all their pictures. So this is just a sampling of our former new grads throughout the program, from anywhere from 1999 to 2016. The picture in the middle is a group of our latest group. We hired 15 new grads in the fall of 2016, and this is just a sampling of them. So now back to Magnet, and back to Magnet. It all ties together. So we're kind of jumping around a little bit, but it all ties together. The new grad program was recognized by the Magnet surveyors as an exemplary practice, and just personally, so I can kind of tie it into Magnet, I did speak to the Magnet surveyors, and they were very impressed with the new grads. And it was kind of funny because I'd say, well, they were a new grad, or they were a new grad, as they were talking to them throughout their survey. So on August 17, 2016, Washington Hospital achieved our second Magnet redesignation. So thank you to everybody in the room, and thank you, Nancy, for supporting us in that big, long journey, and we did it. Yay! That's another yay moment. And we can still say yay even though we're in 2017, because that's a big thing. Magnet redesignation was a big project for us, and it means so much to nursing. It's our highest level of recognition, and it's the gold standard of nursing. It is a commendation for the dedication to patient care and the quality of outcomes that we seek. Only 8% of national hospitals are Magnet surveyed. It's really a small amount compared to the number of hospitals that are throughout the nation. And we're only one of 30 in California that's Magnet certified. We were recognized again, not only for the new grad program, but our advancing degrees. As I mentioned, the new grads are getting their degrees. It's not just the new grads. I talk to nurses all the time that they've just recently graduated with their bachelor's, or they just recently graduated with their master's. I've talked to, I think, probably 2 or 3 nurses just in the last month about them going back to get their master's. So even though I'm a new grad program coordinator, sometimes they come to me about different things, and I was encouraging them because they really want to go back. and get their master's. They're not quite sure in what, but that's really a goal. So it's a continuing growth opportunity. The emergency department was also recognized because they increased their number of certified nurses by 19%. That is great. So we're providing really good care in the emergency department as evidenced by that level of nursing certification. Our wound care clinic was also recognized for maintaining high levels of wound healing compared to national levels. So once again, thank you for letting me present tonight. I'm very excited about the new grad program, very excited that it's Nurse Week and we get to present again. I look forward to our next group of cohort that we're looking to start in the fall, so you guys will see a bunch of new grads running around, probably September or October. So please support them and say hi and welcome them with a smile, because they're usually nervous those first little bit. And thank you to all of our staff, as Stephanie has mentioned, all of our nursing staff, the nurses throughout the organization, and everybody for their hard work and dedication to patient care. Thank you very much. I appreciate it.
Thank you, Sam. Any comments?
I just have to say thank you. You show such enthusiasm, and it sounds like you have a really fun job with a great outcome. So keep doing what you're doing, please.
Thank you. I do. That's really the fun part of my job. The new grads are great, and they keep me on my toes. They keep asking me questions, and it's like...
It sounds like it.
We have to figure it out and teach them the right way, so it's awesome.
Keep doing it.
Thank you very much.
Bernie, you had a comment?
Well, I was just, with Pat, I was impressed with your enthusiasm. At the end of your talk, you said, I'm enthused, I'm happy, I'm great. You know, you didn't really have to say that. It showed in everything you did. Thank you for your work.
Thank you.
Great, thank you, Bernie. Dr. Achanta, would you like to make a few comments?
Yeah, first of all, I want to congratulate all of the nurses for on the Nurses Week. On a daily basis, I'm the beneficiary, and all of our patients predominantly are the beneficiaries of their dedication and hard work. I think I'm really very fortunate to be able to work in a magnet hospital, to actually say that the care that they get, that our district patients are getting, is top-notch, and we could not do it without the nurses. The fact that they recruit us to come and talk and teach, it says a lot about the program and also about the dedication. You know, the continuous improvement is something that they strive for, and I'm happy to be part of it, even though it's a small part. And I can only say thank you, and I can only say thank you that many times.
Yeah, I agree with all the comments that have been made. I have nothing but the highest praise for the new grad program. When the new grads come, it's always an exciting time for me to see them learning, because they're paired up with the nurses on the floor, which I think is so a marvelous way to really learn nursing, bedside nursing, and to learn the culture of this institution. You know, nurses are really the heart of this institution. They provide, as Dr. Achanta said, the bedside care, and the best of nursing care is given here, and that accrues to the benefit of all of our patients. Thank you for your work, and we look forward to the next new grad program.
Thank you.
If I could make one other comment, the success of shadowing other areas. In the operating room, we are the beneficiaries of such programs, because almost 70% of our nurses come from med-surg floors, and they've been retrained, and they are the longest lasting nurses in the operating room. And once again, they bring a different perspective, because they already seen what it takes to be a floor nurse. Now to be the OR nurse, is they make that switch, and they're really, really competent in that. So it's a huge success. I cannot say enough good things about Alice and you know, the whole nursing environment that Stephanie put together. It's amazing, and Sam does a phenomenal job with education. So
yeah, you bring out a very good point. Is that one of the nice things about Sam? I've been here a little bit longer than you, not much longer, but one of the nicest things to see is how the new grads grow in their careers and move on into the ER or into the ICU or the cath lab or the OR and all of these new responsibilities. I mean, it's a beautiful thing. It'd be very interesting to map that out and see how people who come here grow and want to stay here. Thank you again.
Thank you. And Dr. Chacha, I just want to say thank you too for the physician group. It's really not just Magnet, but we have such a good working relationship with our physicians and Dr. Nicholson that I feel comfortable going to Dr. Chanta and saying, hey, pull him out of lane and say, can you present? You know, I kind of pulled Dr. Eichbaum aside and said, hey, I'm going to be talking to you too. You know, can you come and present? And I know Dr. Nicholson, I could come and talk to you. I've had Dr. Martin come and talk. The physicians also, it's such a strong supported program that I've had lots of physicians come to me personally and will talk to me about new grads. If they feel, if they want to give me feedback, hey, can you talk to them about this, or can you talk to them about that, or they're doing a great job. So our physician group also don't hesitate to come and talk to me about the needs of the new grads or just the needs of education for the nurses. So that really shows a great working relationship between our professional groups.
Thank you again, Sam.
Thank you.
Okay, the next item on the agenda is a consideration of the minutes from April 12, 17, 24, 25, and 26. That's a lot of meetings. Do I have a motion?
So moved,
We
Mr.
have-
President.
We have a motion. Do I have a second?
Second.
Dee, can you call the roll?
Director Nicholson,
Aye?
Director Stewart,
Aye.
Director Wallace,
Aye.
Director Danielson,
Aye.
Director Epen.
Aye.
Thank you. Motion passes. Communication, do we have any oral communications, Dee? You know, no cards. Okay, we'll go on to our written communications, which will be from Dr. Achanta, the credentialing action items.
Thank you, Dr. Nicholson. I just want one brief announcement. I just wanted to let you know that this is my last meeting as Chief of Staff to attend the board meeting. I am deeply appreciative of the opportunity that to represent the medical staff for the last 2 years. Next month's board meeting, I'll be on vacation, so again, I want to thank individually all of the board members, Nancy, the administration, and of course the entire medical staff to have the confidence in me to lead them for the last 2 years. It's been a privilege.
You're not off the hook. You still got another 2 years as past Chief of Staff. And
Yes,
we're
sir.
going to need your input and hard work.
Yes, that I promise.
Thank you. We'll hold you to it.
That said, we had 4 new members on the medical staff. Brian George is a physician assistant joining the very busy practice of Dr. Dearborn as a physician assistant. Anjali Sahai is an MD, OBGYN hospitalist. Jonathan Wong is an MD in pediatrics. And Iram Zubair is a MD in OBGYN joining Washington Township Medical Foundation. Temporary privileges were requested for George Bryant, physician assistant to Dr. Dearborn. Emergency temporary privileges were also requested for the same applicant. Reappointments, Jeannie An, MD, Nephrology and Internal Medicine, Khalid Beg, MD, Family Medicine, Stacy Berry, MD, OBGYN, Vache Bezdikian, MD, Anesthesiology, Sibohan Calhoun, MD in OBGYN, Kevin Gersten, MD, Otolaryngology, Thomas Hirai, MD, General Surgery, Ashay Kale, MD, Orthopedics, Nina Katibi, Physician Assistant with me, Megan Nguyen, Physician Assistant with Dr. Halligan, Ajit Sandhu, Pulmonary Medicine, MD, Yasser Sharif, MD in Anesthesiology, and Christopher Wilkins, PA with Dr. Jolly in Cardiothoracic Surgery. Transfer of staff category, Dr. Thomas Hirai, General Surgery, is moving from provisional to ambulatory. Ashay Kale, MD Orthopedics, is moving from active to ambulatory. Nina Katibi, PA, has completed her proctorship and is moving from provisional to active allied health professional. Christopher Wilkins, PA, with Dr. Jolly, is also moving from provisional to active allied health professional. Deletion of privileges. Dr. Berry has has requested for deletion of privileges of argon beam laser and total laparoscopic hysterectomy, as well as the pubovaginal slings. Kevin Gersten, ENT, has deleted sleep medicine privileges. Nina Katibi, PA, has deleted the privileges listed. Megan Newen, physician assistant for Dr. Halligan, has deleted arterial punctures and Foley catheterization. And Chris Wilkins has deleted A-line removal privileges. Withdrawal of applicants, we have 2 applicants that withdrew their application while in process. One is Khalid Ahdoot, MD in radiology for telemedicine, and Ashish Patel, MD, internal medicine. Resignations, Anita Bandia, MD, internal medicine, Elizabeth Crowder, physician assistant with Dr. Carlson, Gavin Henderson, MD, neonatology, Amy Kane, MD, OBGYN, Benjamin Lee, physician assistant with Dr. Jerry Guido, Aline Moorhead, perfusionist, and Andrew Saunders, MD, pediatric hospitalist. All of them have moved on to different hospitals.
Thank you very much. I would entertain a motion for approval of the credentialing action items as presented.
Second.
So we have a second from Director Wallace. Dee, could you call the roll, please?
Director Nicholson?
Aye.
Director Stewart?
Aye.
Director Wallace?
Aye.
Director Danielson?
Aye.
Director Epen?
Aye.
Great. Motion passes.
Thank you.
And thank you for your help over the last 2 years. I appreciate that. Debbie, Service League
Hi.
report.
Good
You've had some
evening.
action recently.
Well, we've been pretty busy. We just had the jewelry sale, the Masquerade jewelry sale. It went well. Numbers were down a little bit. Unfortunately, I can't report too much on it because Cherie is under the weather, so I haven't been able to get a report from her. But it was good. Everybody enjoys it. We work hard, but we have fun. And I can't thank Cherie enough for all her hard work that she puts into this. She's dedicated. We're starting our 10th year doing this sale. Wow, I know. From the lobby to here. And then in the fall, we'll have the 3 rooms. So that's a big jump in 10 years. So I can't thank again to Cherie for all her hard work. And all the volunteers who are there. I mean, there's numerous volunteers that spend 3 days, all day long there. And without them, it would be very hard to make this happen. So thank you to all of them. And we'll have some numbers for you later on once Cherie's up feeling better. Also, gift shop is keeping busy. We're moving on and quite full. Everything I get in, I'm putting it on the floor for the most part. I don't have anything down in my cage, so which is a good thing. That's a good thing. So I'm looking for good numbers, hopefully in the near future. I'm already starting to put things aside for the fall, and that's when our, retail, one thing, most of your sales for the year is in that last 3 months of the year. So that's something I'm really working hard towards, and I can't do it without the volunteers. They really help make it all come together because it's not a one-man team, it's a big team. So I want to thank them all. Let's see, where else are we at? Health and Safety Fair on Monday, that was fun. I enjoyed doing that, handing out evaluations. I didn't find out what the results were, but who won the best display. I'm sure it was well worthwhile. I liked the music, though. It was fun to listen to it, the country music. Let's see, and we have on Tuesday, I'd like to do this shout out. I know we haven't done it yet, but it's normally Volunteer Appreciation Week is in April, and this year it's been postponed to do the luncheon for the volunteers until May 16th because it was just back-to-back with the golf tournament from the foundation holds, which was fine with us. But I want to do a shout out to our volunteers to make sure that if you're going to attend it for the adult volunteers, to get your reservations in right away. It's really important so they have a head count. They're looking to do a head count in the next day or two. And it will be Tuesday at the Marriott, and I don't know anything about it other than the invitation has some Hispanic, Latino, maybe a Cinco de Mayo kind of look. We'll see. I'm looking forward to finding out, but it's a surprise for us, and this is the one time I get to sit back and just enjoy, and all our other volunteers, so we're looking forward to it. I want to thank the hospital for doing this for us. Volunteer hours this last month. Adults, we had 1,636. College students, we had 229. Juniors, 635. Spiritual care, 194. Trainees, 38. And total hours for the month was 2,732. A lot of hard giving to the hospital and to our volunteers. I can't thank you enough because you make a difference. They truly do make a difference. So, any questions that I may answer for anyone? Yes, ma'am.
The masquerade sale.
Yes.
I went for one particular reason, not turtles.
Okay.
But
not even ducks, huh?
When my electricity went out, I was looking for the flashlights. And you had the little lanterns,
Yes.
which I thought was really, really cool. They were all sold out on Wednesday.
Okay.
So I'm putting in a request
Okay.
for fall
Okay.
to have more of those.
Got it. I will make sure. That's
There
one
was-
thing they've said. If you think of things that we really need to have, let us know. And so I will pass this on to Cherie and let Sean know and Casey know.
It was quite an experience with the lights going out for probably close to 12 hours.
Yeah.
And even the street lights went out.
Oh,
So the
wow.
house was really, really dark. So I decided that was going to be a part of my emergency supplies.
Mm-hmm.
And that little lantern is really, really does it.
That's
So
great.
I want more of those.
Okay.
I'm putting in my order now.
They actually had one of those flashlights that were long. It was like yellow, but it
Yeah.
has multiple things to do. It's one of those things that Cherie said, you better get one of those. You're going to make sure you have one. It's in my car right next to me because if it will break the
Break
window.
the window. I've got one of those.
Cut the seat belt. Yeah, pretty cool. So everybody should have one in their driver's seat. So any other questions
Good
I may
stuff.
answer? Thank you, Pat. I will pass that on, I promise.
Great, thank you. Thank you, Debbie. I'm
You're
glad to hear that you're going to have an opportunity to sit back and relax and enjoy.
Thank you. I'm looking
Yeah,
forward
because
to it.
You do such hard work, and all of your volunteers are so wonderful to this institution.
Thank you. We give it
again.
because we love it.
Yeah, thank you. Medical staff report, Dr. Achanta.
Well, I'm happy to report that despite the number of resignations and people moving on, we've kept our roles at the exact same number as we did for the last couple of months. We are at 594. We have 347 active staff members, 3 in the administrative category. We have 17 allied health professionals, 86 ambulatory professionals, and the roles of the ambulatory staff is ever increasing. 4 in the consulting capacity, 29 in the courtesy capacity, 1 in process, and 1 is a locum tenens, 77 in the provisional active category, and 17 provisional active allied health professionals. So that's another number to keep an eye on because that's ballooning in keeping with the modern medicine. And provisional ambulatory 3, provisional consulting 4, provisional courtesy 4, and temporary privileges were for 1, for a grand total of 594.
You expect we'll break the 600 barrier by the time of the end of your term?
I thought I would, but it's maintaining at this level for the last 3 months. So, but then usually around this time is when we pick up numbers. A lot of physicians and allied health professionals complete their training and they're starting their careers here. So I expect, if not by the end of June, perhaps in the very first month of Dr. Choi's term.
Great. Great. Thank you very much. We'll move on to our hospital calendar.
I would like your permission to change the order of reports. We have here this evening Jack Balch, who is prepared to give his Bond Oversight Committee annual report to the board. And rather than make him wait through the rest of the agenda, I would like to give him the opportunity to make his presentation to the board now.
Thank you. I'll be very quick so you have more time to talk later. I'm on the Oversight Committee, one of 5 people, and things have been going very well, I'm pleased to say. You have the report. I see no reason to go over the complete report. We're about 31% complete. We get excellent reports at all of our meetings on our spend and progress, and we're on budget, which in this raising economy and cost escalation, I think is a major feat, and a lot of that goes to the board for, I believe, when you chose to do a negotiated contract as opposed to a lowest bid. You're working together with a contractor, you're controlling cost, you're taking care of your own workman's comp. Your staff is doing an excellent job of watching the change orders. I think your change of architects from the first phase to this phase was a very wise decision. I think that saved you millions of dollars. And I don't know what I can add other than I think you're doing a good job. The staff is doing a good job. You're on budget. We don't get to make a lot of decisions. We just gotta watch to see if you spend too much. And so far, you're doing an excellent job. Any questions?
Jack, I just wanted to thank you for your work. That's a job that can be tiresome at times.
Your cookies are good.
Well, you come pretty cheaply then.
I do.
Thank you.
Thank you.
Seriously, that's a very, very important thing you do, and I appreciate what you've done there.
And thank you for letting me speak early.
Okay, you're quite welcome. Thank you. We'll keep a fresh batch baked for you. Let's move on to our hospital calendar then.
Okay.
Past health promotions and outreach events. On Thursday, April 13th, Sharmi Mukherjee, physical therapist, presented Dizziness, Vertigo, and Fall Prevention. 55 people attended. On Saturday, April 22nd, Washington Hospital's Green Team, the City of Fremont, and other local Tri-City organizations organized the Let's Go Green Together event. This free Earth Day Education Expo raised environmental awareness and shared eco-friendly ideas with people in our district. Attendees learned about recycling and how to save energy. Attendees also learned about planet-friendly options available for everyday living. An estimated 1,000 people attended. On Wednesday, April 26th, Dr. Stacy Berry, OBGYN, presented Solutions for Weight Management. 49 people attended. On Friday, April 28th, Kitayama Elementary School in Union City hosted its annual health fair for students, teachers, and parents. Washington Hospital nurses, staff from respiratory care, and representatives from Washington Township Medical Foundation provided information on asthma, hand hygiene, and other health facts. Over 250 people attended the event. On Saturday, April 29th, Washington Hospital hosted the 11th Annual Women's Health Conference. The event featured an update on the Washington Women's Center provided by Dr. William Degoni, surgeon, in addition to talks on preventing cardiovascular disease in women, nutrition for heart health, and the benefits of meditation. There was also a special presentation by Leslie D. Michelson, author of The Patient's Playbook. Mr. Michelson shared life-saving strategies and decision-making tools for patients and family members to use to become savvy healthcare consumers. Dr. Victoria Liepart, gynecologist, provided the closing remarks. 83 people attended. Also on Saturday, April 29th, Dr. Victoria Liepart, gynecologist, presented Brain Health and Decoding Vitamins and Supplements at Ohlone College's 7th celebration of the World Tai Chi Qigong Day. More than 125 people attended. On Thursday, May 4th, Dr. Vandana Sharma, oncologist, presented Early Detection and Prevention of Female Cancers. 17 people attended. Also on Thursday, May 4th, Washington Sports Medicine provided athletic trainers and hosted a first aid booth at the Special Olympics track event at James Logan High School in Union City. More than 450 students participated. Last on Thursday, May 4th, as part of the Diabetes Matters series, Plomi Granada, RN, presented Insulin, Why I May Need It. 14 people attended. On Tuesday, May 9th, Washington Hospital hosted a free community forum with experts from a Washington, D.C. firm, Holland & Knight, to discuss current major changes to the Affordable Care Act considered by the United States Congress. 68 people attended. Upcoming health promotions and community outreach events. On Thursday, May 11th, from 7 to 8:30 p.m., Washington Hospital will host Celebration of Life. This event will feature stories of survival and hope for cancer survivors and their families. The event is co-sponsored by Washington Hospital, HERS Breast Cancer Foundation, Palo Alto Medical Foundation, and the American Cancer Society. On Friday, May 12th, from 9 a.m. to 1 p.m., Washington Hospital will participate in the Four Seasons of Health Expo organized by the Tri-City Elder Coalition. Washington Hospital staff will provide osteoporosis screenings, and Washington Township Medical Foundation will provide heart health information. Washington Hospital is also a sponsor for this event. On May 18th, from 10 a.m. to noon, Lucy Hernandez, Community Outreach Project Manager, will provide bone density screenings for osteoporosis at the Dominican Sisters of Mission San Jose Health Fair. On Thursday, May 18th, from 7 to 8:30 p.m., as part of the Women Empowering Women series, Dr. Victoria Liebart, gynecologist, will present Nutrition Myths Debunked: Truth Behind Common Diet Beliefs. On Thursday, May 25th, from 5 to 8 p.m., Dr. Sunil Dewan, dermatologist, and Dr. Tam Nguyen, family medicine, will present The Sun, the Beauty or the Beast. The presentation will include screening individuals who have previously had skin cancer, one or more irregular moles, or a sore that will not heal. On Thursday, June 1st, from 7 to 8 p.m., as part of the Diabetes Matter series, Mary Sun, registered dietitian, will present Diabetes. Is there an app for that? On Tuesday, June 6th, from 6 to 8 p.m., as part of the Stroke Education series, Melissa Reyes, RN, will present Living with Stroke and Future in Diagnosis and Management. On Thursday, June 8th, from 6 to 8 p.m., Vita Reed, RN, will present Stop Diabetes Before It Starts. The Washington Hospital Healthcare Foundation Report. The Washington Hospital Healthcare Foundation's 32nd annual golf tournament took place on a beautiful spring day on April 24th at Castlewood Country Club. Golfers joined us on the hill and valley courses for a great day of golf and some fun surprises on the course. Thanks to our generous sponsors and golfers, the tournament generated over $95,000 for surgical services at Washington Hospital. The winner of the Corporate Challenge Cup this year was the team from Fremont Bank. Mark your calendar for next year's golf tournament on April 30th, 2018. On April 19th, at the annual Pathways to Success Scholarship Luncheon, hosted by the New Haven Schools Foundation, Washington Hospital presented a $1,000 scholarship to Yu Shin Bethany Lin, a graduating senior from James Logan High School. Bethany volunteers at Washington Hospital as a baby cuddler and pianist. She will be attending UCLA in the fall, where she plans to major in biology with hopes of becoming a pediatrician. The Washington Township Healthcare District Board of Directors report. Washington Township Healthcare District board members attended the Newark Chamber of Commerce State of the City address delivered by the Honorable Al Nagy, Mayor of Newark, on April 13th, the Fremont Leadership Prayer Breakfast on April 21st, and Citizens for Better Community Spring Celebration on April 29th. Washington Hospital Employees Association, WIA. During the month of April, WIA conducted their annual Sock and Undie Drive. This event is held to collect personal items for the homeless. WIA collected over 40 packs of assorted socks, undergarments, and other personal items for Abode Services and Save. Washington on Wheels, WOW Mobile Health Clinic. During the month of April, the Washington on Wheels Mobile Health Clinic, WOW, continued to serve community members at the Fremont Senior Center, Fremont Family Resource Center, and the Ruggieri Senior Center in Union City. WOW also conducted hearing and vision screenings for 38 students of the Fremont Unified School District State Preschool Program. The total number of community members receiving health care from the Washington on Wheels Clinic during the month of April was 84. Internet and social media marketing. Washington Hospital's website serves as a central source of information for the communities the district serves and beyond. The most viewed pages include Employment, About WHHS, Programs and Services, and Physician Finder. The hospital's social media presence is measured through total reach and engagement stats. The total reach statistic represents the number of people who saw a Washington Hospital Facebook post. Social media posts may reach a user via a news feed, which is most common, a user's page timeline, or via a direct link to a hospital post. The engagement statistic represents users who liked, commented, shared, or clicked on a Washington Hospital Facebook post. InHealth, Channel 78. During the month of April, Washington Hospital's cable channel 78, InHealth, captured new programming including 2 health and wellness programs titled Balance and Falls Prevention and Solutions for Weight Management, and a Diabetes Matter program called Living with Diabetes. InHealth also captured the Women's Health Conference. In addition, InHealth aired one family caregiver program titled Loss, Grief, and Recovery, a sports medicine program named Why Does My Shoulder Hurt?, a Diabetes Matter program called Mindful Eating, and the April Board of Directors meeting. Awards and recognitions. For the 8th consecutive year, Washington Hospital earned the Practice Green Health's prestigious Green Health Partner for Change Award, and for the first time, the Greening the OR Award. Practice Green Health is a national organization with goals to encourage institutions in the healthcare community to commit to sustainable, eco-friendly practices. The Green Health Partner for Change Award recognizes healthcare facilities that have implemented a significant number of environmental programs, along with continuously improving and expanding upon these programs on the path to sustainability. The Greening the OR Award recognizes organizations that drive environmental stewardship within the surgical site. During this past year, the hospital has implemented single-use medical device reprocessing, which will help reduce landfill waste, biohazardous waste disposal costs, and purchasing costs. The hospital continued the food services composting program and significantly reduced water consumption through changes in landscaping, upgrading technology, and replacing old, non-efficient devices. Jenner Flores, RN, is the latest recipient of the DAISY Award. DAISY is an acronym for Disease Attacking the Immune System. This award was started in 1999 by the family of J. Patrick Barnes, who died of idiopathic thrombocytopenic purpura. His family established the award to honor Patrick and to thank nurses who, with their clinical skills, compassion, and extraordinary work, impact the lives of patients and their families. Jenner has received multiple compliments from patients, families, and his peers throughout his 8-year career here at Washington Hospital. One patient wrote, "Being in the ICU was not easy, but Jenner did an amazing job taking care of me. He was attentive and clarified everything to me so that I understood what was going on. More importantly, Jenner provided comfort, which really kept me at peace. His vibes and work ethic made me feel like I was really taken care of." Another family member wrote, "Jenner is an excellent RN, very knowledgeable, helpful, considerate, patient, and kind. He is a gift to the medical community and his patient. We are very grateful for all he did for my husband." Jenner is attuned to his patients' physical and emotional needs and continues to provide positive experiences every day for his patients and their family members. He emulates what the DAISY Award stands for and Washington Hospital's patient-first ethics. Washington Hospital and members of the medical staff, including Washington Township Medical Foundation physicians, were recipients of the Best of Fremont 2017 awards and honors. Readers of the Bay Area News Group newspapers cast votes online to determine recipients. The 2017 Best of Fremont winners are Best Hospital, Washington Hospital Healthcare System; Cosmetic Surgeon, John Romano, MD; Dermatologist, David Gorsalowski, MD; Best Doctor, David Chang, MD; Best OBGYN, Elizabeth Kirkjohn, MD; Ophthalmologist, Stephen Anderson, MD; Orthopedic Surgeon, Alexander Saw, MD; Pediatrician, Susan Degoni, MD; Podiatrist, David Laver, DPM; Urologist, Mark Saleh, MD. In addition, several physicians were also honored. The 2017 Best of Fremont honorees are Group Health Provider, Washington Hospital Healthcare System, and Washington Township Medical Foundation. Cosmetic Surgeon, Ario Barzin, MD, Eric Okamoto, MD. Dermatologist, Sunil Dewan, MD. Best Doctor, Diane C. Martin, MD, Alexander Saw, MD. Best OBGYN, Demetra Burrs, MD, Siobhan Calhoun, MD, Scott Kramer, MD, and Victoria Liepart, MD. Ophthalmologist, James Kahn, MD, Kenneth Lowe, MD. Orthopedic Surgeon, John Dearborn, MD, Jan E. Henstorf, MD, John Jaragito, MD, and Russell Nord, MD. Pediatrician, Rodora Dela Cruz, MD, Peggy Fang, MD, Dennis Unson, MD. Podiatrist, Lawrence Elner, DPM, Warren Johnson, DPM. Spa or Wellness Center, Washington Wellness Center. Additional events and announcements. National Hospital Week takes place May 7th through the 13th. During the week, Washington Hospital hosted a series of events to celebrate hospital staff and volunteers who, day in and day out, support the health of the community through compassionate care, constant innovation, and unwavering, unmatched dedication. Washington Hospital kicked off celebrations with the annual Employee and Volunteer Health and Safety Fair on May 8th. The event theme, Saddle Up for Good Health, featured 20 wellness booths to educate staff and volunteers on how to best maintain health and safety for themselves as well as for patients. Other Hospital Week festivities include daily tours of the Morris Hyman Critical Care Pavilion construction site, mock-up emergency, ICU, and med-surg rooms for the pavilion, appreciation meals for staff and volunteers, and a Green Team-sponsored Bike to Work Day Energizer Station on May 11th. National Nurses Week runs from May 6th to May 12th. Every year, the National Nurses Week focuses attention on the diverse ways America's 3.1 million registered nurses work to save lives and to improve the health of millions of individuals. This year, the American Nurses Association, ANA, has designated 2017 as the Year of the Nurse, and this year's theme is Nursing, the Balance of Mind, Body, and Spirit. At Washington Hospital, nurses will be celebrated at a tea reception on Friday, May 12th. For more information on any of the programs mentioned, visit WHHS.com or call 1-800-963-7070. And please follow us on Facebook and Twitter.
I'd like to announce the Employee of the Month for May 2017. It's Ellen Strack. She's a clerk and certified phlebotomy tech in our clinical lab. Her knowledge and integrity and compassion, dedication and friendly nature has made her an excellent team player and a perfect recipient of the award. She joined Washington Hospital in 1996 and quickly earned high esteem from her peers. She is skilled in neonatal heel sticks and has guided many new phlebotomists to confidently draw our pediatric patients. She's also skilled in many areas of the lab, front office, pathology, and successfully managing our newborn genetic screening program with medical records, physicians, and nurses. She's kept a very professional and friendly demeanor throughout the years and always practices good work ethics and maintains a positive work environment. She loves to spend her free time in Groveland, where she has a second home. She has 3 children and 4 grandchildren ranging in ages from 9 to 18, who affectionately call her Nana. Now, I have also had the pleasure of receiving a message from Ellen. She sent me an email. It's been a good career here at Washington Hospital. I really love doing phlebotomy. When my daughter asked me to go to school with her. She also worked here at one time for phlebotomy in 1995. I said, I will see if it's something I can do or not. So happy it turned out to be a good fit. I don't draw on a regular basis anymore as I'm in the front office now. I do miss my regular patients and seeing the nurses. I'm retiring at the end of this month, and what a nice exit. I was so surprised. One of the best programs you have. It is hard for me having that kind of attention, but so appreciate the recognition. I've lived in Fremont since I was 4. Washington Hospital employees all work together for the good of patient care in this community, and I know as I get older, I will rely on that. Thank you, and I only wish the best for you, your family, and your continued care for this community. Thank you, Ellen Strack. Absolutely lovely.
Wonderful words.
Yeah. Congratulations to her.
Yes, yes, indeed. Thank you, Nancy. Okay. We'll now move on to our Arlene Kaizen report.
We have Raju Tiara, who is the technical manager of medical imaging at Washington Hospital, speaking, as well as Mike Engel. I'll tell you a little bit about Raju. He began his career at Washington Hospital in 1980. He is a long-term employee. He was promoted to the position of technical manager in 2003. In that capacity, he oversees the operations of the medical imaging department, including diagnostic radiology, CT, ultrasound, nuclear medicine, and MRI. He holds a master's degree in English literature and a bachelor's degree in science. And I think I'll do Mike's introduction now, too. I see them both there together. He is the Senior Director of Ambulatory Care Services. Began his career in Washington Hospital in May of 2008. He oversees the operations of Washington Urgent Care, Washington Outpatient Rehab Center, Washington Radiation Oncology Center, Washington on Wheels, Ohlone College's Student Health Center, Washington's Medical Billing Unit, the Corporate Compliance Officer for the DevCo, I think, Medical Property Management, Little Washington Township Child Care Center, Sports Medicine Program, Inpatient and Outpatient Medical Imaging, Gamma Knife and the Nuclear Medicine Departments, the Women's Center, and the Wellness Center. He also plays an integral role with the administration of the Development Corporation. He holds a master's degree in business administration from John Carroll University in University Heights, Ohio, and a bachelor's degree from Hiram College in Hiram, Ohio. I bet he's a Cavaliers fan.
Thank you, Nancy. Thank you for allowing us to come today to share the work that we're doing in imaging with the lean. Imaging started this lean journey last June, and I say this because we also have the lean journey in the Women's Center as well that was presented previously. We've done 4 workshops in imaging, and we started with the value stream mapping workshop. And with a multidisciplinary team, the following problems were identified in the workshop, and we had high turnaround time, over-processing of orders, and delays and confusion between lab and imaging sequencing at times of some of the services. So the targets that were established in the value stream mapping was to reduce the imaging lead time by 20% and reduce patient wait time by 10% and increase the percentage of patients ready at the time of service. After the value stream mapping workshop, we followed up with the 5S workshop, the flow and transport for ED and patients having imaging procedures, and this was done last December, and then we did the nursing functions and outpatient CT flow in January of this year. Some basics of the department. We run 24/7 in the hospital, but we also have the outpatient services here in this building where we have the outpatient imaging center and the women's center. The throughput and wait time are influenced by the time of day and volume surges. So if the ED, as an example, is busy, so is imaging. And then we have services include CT, X-ray, MRI, nuclear medicine, and the ultrasound procedures. We interface with multiple departments throughout the hospital. As an example, we have the inpatient, the ED, and OR, to name a few. And then now Raju will walk us through some of the workshops that we did and the improvements that have been made.
Great. Thank you, Michael. Good evening. I'll be talking to you about 3 different workshops that we did as a part of our lean journey. Usually the very first workshop is defined as the 5S. The 5S is standing for sort, set in order, shine, standardize, and finally sustain. As Michael said, all of these workshops were conducted with a multidisciplinary approach with one goal in mind, purely one goal in mind, and that is to improve our patient care no matter how small it might be. Some of the goals of the 5S essentially are to ensure that the supplies in CT, X-ray, and ultrasound are in sufficient quantity. They have to be available at the right time, in the right place, in the right amount, but never in excess. To organize the storeroom so that it's room to improve ease of finding supplies, and then finally to declutter the supplies. This is a slide of before and after. As you can see, the before slide shows multiple boxes stacked over one another, sometimes of needles and catheters of different sizes all placed together, making it very hard for the staff to find locations. Whereas the after workshop, the storeroom is neat and clean and properly labeled. I must add that the color coding scheme was something that came out of the workshop by one of our employees. we usually get supplies from multiple areas like the pharmacy, our storeroom, the hospital storeroom, and external sources. So they created a color scheme so that anybody walking into the room can easily tell where the supplies are. Moving over to some of the improvements, when the goal of improvements was to reduce the number of trips staff was making to the storeroom for out-of-stock items. At the beginning of the workshop, we were realistically leaving our rooms at least once a day. That doesn't sound like a very big thing, but to leave the room while we could be doing patient care, it makes a lot of sense to us. But at the end of 30 days, we were able to cut that down by a third. The other important was to continue to track the inventory. During the workshop, we were able to reduce our inventory by $7,000 from $47,000 to $40,000. And I'm happy to say that in the past 90 days, we have been able to level that inventory with goals for future further reduction. This slide is truly showing a success story of how engaging our own staff in these workshops goes further. Here's our nurse, Jennifer Kesey, who after the workshop was over, took it upon herself to go a step further. Not only did she use the department's color coding scheme, she then went to the med-surg unit and brought that scheme over. So on the shelf, as you can see, those long stripes of pink and yellow, those are the med-surg color coding schemes. Her thought was, what is a nurse going to do when I'm not here? On a weekend or after hours, if a med-surg needed a catheter, she could easily come, use the hospital's color coding scheme, and find the supplies. So this is really a positive for us. The second workshop was around patient flow and transport. Some of the problems we learned was that the wait times increase as the volume in our ED increases. As you all know, we have one of the busiest ERs, but their peak time usually is between 2 p.m. and 2 a.m. For that 12-hour period, they're at the max peak. And those are the times when we see a reduction in our turnaround times. One of the things we noticed was there was a limited standard work around the signaling of patient status. We had developed a system in place where whenever the nurse started an IV, whenever the consents were all signed, and whenever the lab tests were available, she would log them into Epic, and Epic would send a signal to the CT tech in the form of a green icon telling him that the patient is ready. What this did was eliminate multiple phone calls back and forth. And as you know, every phone call is an interruption in patient care. So that was a big plus for us. And then the delay in transport from the inpatient unit causes waits for our patient and for the imaging staff. Prior to the workshop, we had one particular location designated for all transports. We have 2 transporters serving 3 different modalities, ultrasound, X-ray, and CT. So it was very hard for them to figure out which patient should I get next or who is more critical patient. So the membership out of the workshop created separate areas for X-ray, ultrasound, and CT, and then also created a place for all the stat orders. So the transporters could just come and go and bring the patients in the right process. We also developed new processes to accommodate volume surges in CT. And then we're going to start a new education program of imaging readiness, and this will start at the time of nursing orientation. So that we want to educate the nurses who are coming into Washington Hospital of what our needs are, what the importance of a proper prep is, and the timeliness of prep, and so on and so forth. This graph really shows significant improvements that we have accomplished over time. Prior to the workshop, our lead time from the time an ED physician ordered a scan to the time scan was started was about 64 minutes. In the past 90 days, we've been able to cut it down by 30 days by half. I can't take credit for all of this myself. It's a lot to do with the ED physicians and the ED staff helping us out in the signaling process. But we need to continue working on it, and because the shorter the turnaround time, the faster we can get an ED patient either discharged or admitted in a timely manner. The final workshop was around nursing intervention and outpatient CTs. One of the things we noticed was our RNs, when they were busy doing a procedure or in the middle of helping a physician, were getting multiple phone calls. Over the course of time, they had just taken it upon themselves to schedule all the biopsies. And these are all the phone calls that were coming in constantly. So we changed that. Now the central registration department is doing the scheduling, and then they send a signal to the nurse saying, hey, I want you to call this patient, and that could be done any time in the day. The RN workflow, as I stated, again, depends on the transport delays. But one other thing we noticed was in the outpatient arena, prior to this workshop, the technologist or the RN had no way of knowing where the lab tests were done, what the results were, and how long ago they were done. So what we have done with the help of our IT department, at the time of registration, actually time of scheduling, our registration staff will ask the patient where this lab was done. Sometimes they're done out of Fremont, somewhere else. And if the tests are done within Epic, then the IT department was able to take that information and put it right on the technologist's screen. So the tech didn't have to run around wasting time. They could go straight to the patient, making it possible for less wait times, if you will. The other important thing that happened over the course of time was the processing of a biopsy specimen by an RN. Prior to lab upgrading itself to Beaker, this was a manual process. For every, Dr. Nichols, you probably know this better, for every biopsy specimen you do or every fluid you collect, there could be multiple orders. So for every order, our nurses were touching the Epic screen 7 times before it was processed. With Beaker, we've created individual barcodes for each and every lab test. So now all the nurse has to do is scan the barcode, and everything else is done behind the scene. That has been a significant improvement in our nursing workflow, getting a much more time to spend with the patients rather than doing the paperwork. And that, in essence, brings us to our current next steps. We have been meeting with our senior management on the process owner board. We have just now started discussing the frontline board. The frontline board, to me, is probably the most important part of the Kaizen process, because this actually brings the staff. It engages the staff in bringing problems to us and then helping us resolve them. We give them the ownership, and I think that we'll see a lot of improvement from that. On an ongoing process improvement basis, we need to continue to look at the transport process. We need to look at improving our communication, our own communication with the other areas of the hospital. And finally, an ongoing continuous education with the nursing staff. It's really vital. With times when they're really busy, they just need to be reminded how important the preps are, how important the timeliness is of a certain order. That brings us to the end of our presentation. I'll be more than happy to take any questions.
Any questions?
I love the color coding. As you know, in medical record history, we color coded everything we could add a color to for the filing system. So great idea.
Yeah. And this came from our staff. I must, the compliments go to them.
Great time saver.
Yeah, it's great work, and really nice to see the decreased lead time from the time a study's ordered to the time it's done. That's really
Thank you.
Key to patient care.
Thanks.
Thank you, Mike. Thank you, Raju. Construction report, Mr. Fayan.
Dr. Nicholson. Okay, so we have basically, continuing good news. The project is continuing on as scheduled, as we talked about last time. The loading dock becomes sort of the long pole in the tent in terms of that being something we're going to continue to watch. Needs to get done at the same time as the rest of the building. You can see some progress in the finishes. This is in the biomed shop in the basement. We're starting to move cabinetry into that area. This is a shot of the emergency room reception as you walk in the ambulatory door and basically triage area. The CT scan and X-ray rooms in the in the emergency department are now starting to come along. And this is a shot of the new main lobby towards the circular skylight. You can't see it very well because of all the equipment in there, but that's the view as you walk into the new building. Here you can see the second floor ceiling starting to be put in place, the hard grid ceiling. This is a shot of that atrium skylight and some of the steel structure. I think we saw this from a distance, but this goes all the way up and down that atrium area. This shows you that the landscape area is getting more and more finished. This is out looking towards Bart Way. This is a shot that shows you on the portion of the outside gardens that are facing the existing hospital. It actually goes up multiple stories, so you can see from the third and the second floor down into the atrium and the planting area. We've made actually very good progress on the exterior metal panels, so it's not done yet, but we're getting close. Here you can see now up on the third floor, we're moving on to the electrical components up there. This is the beginning of the work of the new loading dock, and so there's some storm drain things that have to be put in place. There's a lot of trenching and underground utilities going in that area right now. And this gives you a view of where we are today with the project. Our schedule's maintaining itself, and I'll take any questions.
Questions? Any questions? Great. Thank you very much, Ed.
Thank you.
We'll move on to our quality report. Mary Bowron.
Good evening. Thank you. Yes, it's a mouthful.
Hear this from Dr. Akawili.
Yes, exactly. You're right.
Each year she keeps adding a new letter.
Yeah, that's what they keep on saying. Don't worry, we're not going to go all the way to the end of the alphabet with this. So tonight I wanted to be here to discuss with you a quality improvement initiative that the ICU team has worked on and seen a great deal of success with here recently. We wanted to be able to share that with you. The initiative is called the ICU Liberation ABCDEF Collaborative. It is sponsored by the Society of Critical Care Medicine. The purpose of this collaborative is to take an opportunity to improve critical care patient outcomes through a set of specific interprofessional evidence-based interventions. So you're taking basically a bundle approach to improving the outcomes for our patients that come through critical care. This was sponsored, as I said, by the Society of Critical Care Medicine. It's actually has come to a completion in February of this year, and we have been able to, get together our data and results, which is what we want to share with you here this evening. We were one of 67 hospitals that were chosen to participate in this in the nation. We had continuous meetings with groups to kind of collaborate, look at how each person is doing with their interventions and share ideas. And our last and final meeting was here on April 11th this year. The national representation, as you can see, is across the United States. There are 3 regions. We participate in the West Coast participation of the program. And to give you some background on what we have done with the bundle of ABCDEF is we sort of were an early adopter of the program. Around 2010, we really started looking at what do we want to do to decrease and manage delirium management of patients in critical care. There were a few academic hospitals who participated. Very few community hospitals at that time were doing it, but we started looking into this in 2010. Looking at the evidence out there, what is the best way to implement this bundle to decrease delirium in patients, and then the latest development in this bundle has been the addition of the F, which is the family-centered component of the bundle, and that was implemented by Society of Critical Care in 2014. We had looked at family assistant programs here as early as 2008, but we've been able to take it to a new level in 2014, which you'll hear about as soon as we go through the elements. But before we start even talking about that, it's important to recognize what is delirium. And delirium is basically when it's a disorder of functionality when a patient can come into a setting like critical care. It's a different environment. They tend to be critically illness. They get confused. They have a hard time being oriented to where they're at. It's very confusing, even knowing sort of what time of day it is or if it's in the evening, especially patients who have this serious medical illness. We also give them a lot of medications while they're here. Those can interact, and next thing you know, you have somebody in a full state of delirium and confusion. And the worst part about it is that these patients are already sick, they're already in ICU, intubated. You don't want them to have to be dealing with being delirious on top. It creates a lot of fear and anxiety for patients and their family members. So we recognize that and want to do whatever we can to prevent that happening while the patient's in here. And really the standard approach is by looking at implementing this bundle. Data collection is a key part in this so that we can know where we're at and what we're doing and areas we need to improve. Critical care has been very meticulous about how they collect their data in this area and compared it to national regions to see sort of where we lie with the benchmarks of our other people participating. Some of the areas we looked at were the demographics of the patient. What were the outcomes patients had after we implemented the bundle? How well were we compliant with the bundle? Did we do the interventions when we could have? And if not, what did we learn and make changes for to make sure that we could do them better? So a quick overview of the bundle before we get into the details are the A is basically assessing for preventing and managing pain management. B stands for the both, spontaneous awakening and breathing trials of patients. This is called sort of wake up and breathe and trying to help patients with that process. C, choosing the safest, effective, evidence-based sedatives, really looking carefully at how are you managing the medications of these patients. And D, delirium assessment, continuing to use validated tools that are standardized and make sure that we can be assessing the level of delirium. We can catch it early and make the appropriate interventions. Early mobility, of course, is a big deal for anybody in the hospital, but especially in ICU. If a patient can be mobilized earlier, you tend to decrease all sorts of other hospital-associated incidences that can happen with them, like pneumonia or skin issues, that sort of thing. And F, the most recently added one, is the family engagement. So to go into detail with these, going back to the A, assessment and pain management. So what we've worked on basically here is making sure that we can assess this patient's pain management well. Obviously, these patients, when you're incapable of speaking and are being able to articulate what kind of pain you are in, we need to have a way of looking at these patients and measuring their pain and being able to intervene if we can, recognizing that they cannot verbally do it themselves. So we brought together as part of our initiative, educated all the staff and implemented the critical care pain observation tool, otherwise known as COPT. It's a new scale to measure pain. You come in and you rate the patient, look on facial expressions, on muscles, and are they contracted, are they agitated, things that you can look at objectively and say, this patient looks uncomfortable to me, even though they can't articulate it, they do. You use an objective scale, and then you can medicate according to that. But we have to be able to be in there and assess that frequently. So our measure for this was we expected the nursing staff to be able to assess the pain at least 6 times every 24 hours. So there was a lot of pain assessment that was done. And you can see here with on our scale on the top is the Washington Hospital. The black line is above the 90% benchmark, which is we were able to assess these patients as frequently as we set out to do, which is good because it gave us an opportunity to manage the pain better. We had an overall 50% increase even in one of the months, and we've been able to keep pretty standard sustaining with that. Moving on to B, which stands for both, spontaneous awakening and breathing. So these patients, as the evidence has showed that basically the deeper a patient is sedated while in ICU, if you go into a really deep level of sedation with them, actually some of the outcomes can be worse for them. They can tend to have delirium more often. They can tend to have a much harder time coming out of the sedation and even be more confused. So it's important to find a way to balance that. You want light sedation, but you also want to control the symptoms in the patient so that they're comfortable. So the way that we have done this with the bundle is looking at a daily, every 24 hours, assessing the patient for the level of sedation they're at. And what you do is a spontaneous awakening trial. So backing off a little bit on the sedation, seeing does the patient wake up calmly? Are they able to open their eyes? Can they squeeze your hand back? Can they respond to verbal responses? And if that screening goes well, that's how you can begin to titrate down the level of sedation and decrease it and avoid them getting into this deep sedation with side effects. After you've done that, you need to move to the next step, which is spontaneous breathing trial, which is seeing how close can this patient get to breathing on their own. They're on mechanical ventilation. So can we pull back a little bit on that? Can they breathe spontaneously themselves, maintain their O2 sats, things like this? And if that screening doesn't work and they are not stable, of course, immediately we recognize there's a failed trial there. We're not going to try to pull them off too early. But if they pass, it gives you an opportunity to get them more awake and alert and get them closer to breathing on their own, which leads to having patients on ventilators for a shorter period of time. So again, a lot of this is assessing for this. It needs to be assessed frequently. And this assessment needs to be happened on a scheduled, standardized process every 24 hours, which we've had a lot of success with, always been above 90%. And in fact, the outcome for our patients has been that we've been able to do this assessment for the SAT prior to the breathing test 100% of the time, which is a good success. Moving on to the C, this is considering your choice. You're focusing on, do we have the right meds? Are we using the right meds for this patient? Everybody's different. You need to look. You can give one patient a narcotic or a sedative and they can react differently. So it's fine-tuning the sedation that's specific to the patient. You need to be able to go in there and check that. And we were doing hourly sedation assessments even prior to our collaborative participation. But we continued through this collaboration to really track and look at, are we doing that sedation assessment frequently enough? We use a standardized tool recommended by the collaborative and ended up being able to do 6 assessments within 24 hours. And we achieved that greater than 90% of the time. So again, if you catch the right medication, you're not going to be dealing with the side effects, and managing the medication sooner leads to less delirium. So delirium itself is part of the bundle. It's assessing for that and making sure that you are assessing it. We were doing it in 2012 every shift. Moving into the collaborative, we looked at doing it twice in every 24 hours because delirium can have a quick onset. It can sneak up on you fast, and if you get in early and manage it, again, you're going to save the patient the suffering of delirium and other bad outcomes from it. So we've had success with being able to do that as often as recommended, above the goal of 90%. Early mobility and exercise. As I mentioned before, this is the E part, early mobility and exercise. You always want to make sure that anybody who's in a hospital, right, that gets mobilized when they can and that it's done early. But it is especially important in a patient like this in critical care, because not mobilizing a patient can lead to other bad outcomes that we don't want to happen with them. So we looked into an initiative where we formalized a mobility protocol so that everybody has a standard protocol and they know exactly what to look for to assess mobility. One of the key points to this is you have to understand what was the patient's baseline for mobility even before they came into the hospital. So an 85-year-old who's admitted to ICU, you're going to be looking at a different assessment interventions for mobility than you might do somebody in their mid-50s who had was probably more mobile or walking faster and easier. So it's recognizing how to do that and get them from where they were to try and maintain that or get them back to where they were prior to their ICU visit. Again, that comes with a lot of assessment, making sure that they're safe to get up and move and that they are screened appropriately and that they are mobilized as early as possible. This is where you come in with really looking at the multidisciplinary aspect of the team. PT, OT, nursing, communicating with them. It takes an entire team to get this bundle up and running. And we basically had a greater percentage of patients mobilized than the nation. You can see that everybody is sort of struggling to get to that 90%, but overall, a threefold increase in patients with early mobility has been a great success for us, getting them up earlier. It requires a lot of communication, a lot of planning, coming through rounds, but we were able to achieve that. Family engagement empowerment, again, that's the newest one. To me, I think this is probably one of the best parts of the bundle. There's a lot to be said for initiating programs where you involve the family in the care. This is an initiative that was brought forward that involves you actually in participate. When we do the multi-disc rounds, family participates in it. If you have a family member at the bedside or wherever the advocate is at the bedside, they participate in the multidisciplinary rounds. They're stopped, asked a couple questions. It gives the family time to ask you questions. They can inform you of something that may not happen. They're in there all the time. They know the patient well, and they can help us communicate with what they think is going on. It also gives us an opportunity to let them know about this bundle and why we're doing it and why it's important and how it can improve their patients, their family members' outcomes. Family conferences are a big part of that. You have to come together as a group, explain what we're trying to do, and explain the benefits of it. Again, a great source of communication, which always tends to increase the quality of a patient experience if you have good communication. Charge nurse visits, they visit patients even after they leave the ICU and go up and meet, and they've already built a relationship with family and the patient. It's a good sort of follow-up. They don't just drop off from ICU. We carry that sort of continuum of care into a different setting. ICU diaries provided. This is a really useful tool. So it's, again, getting the families engaged in the care. They can sort of document what happened. A lot of these patients, aren't going to remember what happened, and that's scary, and they're fearful. And I think, sitting down and being able to look afterwards and say, okay, this is what happened. This is what they did for me. This is how I got better. Or, it kind of fills in that black hole, which can cause a lot of anxiety if you're not aware of what happened to you at such a sort of scary time. And we did some EPIC modifications for data collection in this. The use of the EMR has been very helpful in collecting the data on this and reminding staff when to document their assessments, and of course, how do we collect the outcomes. And so it's been another useful tool for us. So basically the outcome of this is that we had a 20% increase in compliance. This is greater than the national and regional averages, but the documentation, the measure that we use for that is as long as it's documented at least once every 24 hours that we had an interaction with the family, we considered that compliance. So a great deal of compliance with involving the family members. So nationally, the hospitals have seen some great outcomes from using this ICU Liberation Collaborative. ICU length of stay, decreasing by a half a day from where it was before at 3.5 days, coming down to 3. Half a day may not sound like much, but it is huge. When you can decrease your length of stay anywhere in the hospital by half a day, you can get some great outcomes from that. If you can get a patient out of the acute care setting that they need or whatever it is and get them into the right level of care anytime earlier, especially half a day, is a great impact to the overall quality of care. Not to mention the patient flow that you can achieve, and when you get people into the ED as a result, you can get them into ICU or get them the care they need. Pretty significant quality outcome there. Hospital length of stay, same reason. We decreased that by half a day. Overall, the nation has. Mechanical ventilator hours, the number of hours that patient is on the ventilator. The median time was 65 hours prior, brought it down by 10 hours, 55 hours. Anything you can bring down to help, because you're going to decrease that patient from developing a pneumonia while they're on the ventilator. Never delirious. 41% of the time patients didn't experience delirium before. Now it's 56% of the time. So over half the patients, if this is implemented correctly, cannot have to deal with the effects of being delirious. But specifically, if you look at our hospital and some of the outcomes we had, as I mentioned before, we were sort of early adapters of this program, so we had done quite a bit of the interventions prior, but I think it just really helped us fine-tune those and standardize them. And as a result, we were able to make sure that our pain assessments were done frequently and managed, and of course, improving the family engagement has been a big part of our success here. And we had greater percentage of patients that received the early mobility. So we didn't wait until this patient was extubated and ready and not sedated anymore and ready to get up. We tried to do it as early as possible, even if it's leg movement, even if it's sitting them up, dangling the legs or anything. That's early mobility that will help with their overall outcomes. Decreasing in average ICU length of stay by half a day also happened for us, which was great. And a decrease in our median hours for mechanical ventilation. Ours were 20 hours, decreased by a quarter. That's very significant. Again, patients far less likely to develop pneumonia. And we've seen that in our ventilator-associated pneumonia. Rates have gone down pretty significantly, and I think some of it's part of this bundle. But it was interesting, when I was preparing for this presentation, I listened to a lot of podcasts from hospitals that have been trying to do this. And over, you hear a reoccurring theme. If you do not have administrative buy-in, you're not going to be able to accomplish this. It's not going to be good. Your outcomes aren't going to be good. You need to get the administration to buy in and support it. And I think that's one of the reasons we've been so successful for this. You know, obviously our CEO, Nancy Farber, has been very supportive in letting us implement this collaborative, has been strongly supported by Stephanie Williams and leading the nurses, supporting them in this. You can see how many times she showed up by the pictures and was there. And same with Dr. Akawili, who's absolutely a believer in this. She has passion for this, and she's done extremely well and had great outcomes. In addition to the nursing staff and everybody, like I said, it takes everybody. You have to have PT, OT, you have to have nursing, pharmacy, everybody's involved in this, and it takes a team effort. But we've had a great deal of success really from having great leadership. And you can tell that by the recognition of performance that we got. We received a Top Team Performance Award. We were recognized by the Society of Critical Care Medicine for the top team performance for the overall bundle compliance, which is pretty significant because we were able to make a significant enough impact on every aspect of it. One of the other awards that we have received is the specific one to the E, which is the early mobility, which was very impressive for them to be able to receive that in critical care as our West Coast region. And the next steps moving forward, we would like to continue to focus on the patient-centered care and family engagement because we recognize how important that is. And the critical care team will continue to make that part of their rounds and continue to grow on that experience and some of the benefits we've seen with that. Looking at implementing some more early mobility scales testing. It's very important to use validated tools in this process. We've done that. We'll continue to work towards that. And of course, sustaining it. We want to sustain these outcomes so that patients don't have to suffer through being delirious while they're here or having any of the issues that are associated with that. I think it's important also to have regular reporting of performance hospital-wide. It's great. A med-surg team should know about this. They should know what these patients are having while they're in critical care, and we can communicate about it. And some of these interventions, you know, you could even argue do well outside of ICU. So it's great to share the lessons learned, and we'd like to focus more on that again.
Thank you very much.
Thank you.
Any questions or comments?
Very impressive.
Thank you.
Yeah, this is really good stuff. This is really important stuff because the bundle is really the essential element of excellent care.
It is.
And it's really nice to be able to see this progress over the last nearly a decade that Dr. Akawili and the whole team has been working to make this happen. You know, it's really impressive when you go walk through the ICU and you see somebody who's on a ventilator and they're walking in the ICU. It's, you know, it kind of blows you away for somebody like me who was trained decades ago to see what we can do nowadays with a dedicated team with focused goals. And that's what the ABCDEF does, is it helps the team focus on each of those individual elements. And they're doing a very good job.
They are. I mean, that was one of the things that stood out for me too when I was researching this. I said, mobilizing ventilated patients, how does that happen? You know, and they get this mobilized ventilator, and then they secure the tubing, and how they get the patient up, and how they do safety checks to make sure the level of, you know, that they're not obviously too sedated and things, and what a difference it makes.
It's
and what a
really
difference it makes for
hard to
the
do,
patient to get out of bed.
but it makes a huge difference.
So yeah, I've seen a lot of bundles. We work with a lot of bundles in infection control and quality, and this one is really impressive and was great to learn about. They've done a great job in ICU. They really have.
And I agree with your point as far as moving some of these things outside of the ICU, and probably one of the more important parts is the delirium and the family engagement.
Yeah, definitely. Great helps.
Mm-hmm.
We have furniture that will accommodate a member of the family spending the night in the same room as the patients in critical care and also in the mid-surg rooms. They're all single rooms. And we looked long and hard for a couch that could become a daybed. And I think we got one, and it's a place where a family member can pass the night comfortably. And that includes them. And I think it's also really good for the patients. Because I think on some level they know when their family members are there.
Yeah.
And I think that this whole bundle has been pushed forward on the sheer willpower of Carmen Agulli, and she is to be commended. What an extraordinary thing she has done to improve patient care.
Assembling the team, pushing the team,
Yes.
ensuring compliance, all of those things.
Yeah.
Just she's such a cheerleader for the
She
whole
is.
process.
She's wonderful.
Yeah. Great. Thank you very much, Mary. Okay. Quality always before finance, but we still go to finance.
No margin, no mission.
Right, well, we know that.
And there's good news for March.
Oh, good. Okay.
So tonight we'll be looking at March 2017 results. As you recall, the operating bottom line early in the year was challenged. And in fact, by October, we were running short of our budget on the operating bottom line by a bit over $8 million. The good news is in March, we've closed that gap, and for all intents and purposes on a year-to-date basis are even with budget. So it's good news coming, and let's get into it. So we'll start with our operating indicators. Average daily census for March was 24.5 above budget and 194.6. The house was really busy at that level. We had 1,163 admissions. That was 43 above the budget. And our patient days were 759 above budget at 6,033. Outpatient observation equivalent days were 18 below budget at 220. And our average length of stay for the month was 5.62. We'd expected 4.71, so we did have some long lengths of stay in March. Looking at utilization, case mix index for the month was pretty close to budget at 1.569. We had 146 deliveries, just 2 below budget. Surgical cases came in 3 below the budget at 413. That included our joint replacement cases that were 7 below budget at 151. Neurosurgical cases came just under budget at 26, just 1 below. And our cardiac surgical cases offset that, 1 above the budget at 11. Cath lab procedures for the month, cath lab was busy at 445 procedures. That's 31 above the budget. Outpatient visits for the month were 159 below budget at 7,749. And our emergency room was below budget, but still very busy at 4,658 visits. Quick look at the cath lab activity, peripheral vascular activity, and cardiac activity almost even in the month. 42% cardiac to 40% peripheral vascular. Looking at FTEs, full-time productive FTEs for the month were 61.5 above the budget at 1,332.2. With that level of activity, we had a lot of people working here. Non-productive FTEs for the month were 51.8 below the budget at 138.1, giving us total FTEs that were 9.7 above the budget at 1,470.3. But our FTEs per AOB, that's our productivity measure, came in at 5.71, where we had budgeted 6.42. So, you know, we were running pretty thin on people again in March. And let's jump into the financial results. As always, we'll look at our Governmental Accounting Standards Board presentation. This is the presentation used for our audited financials. Total patient revenue for the month came in 7.5% above the budget at just under $200 million. Contractuals for the month, though, came in high, 78.1%. We gave it all back. Again, we had 75% government payer mix in the month, and that's been a challenge. but we still ended up with net operating revenue pretty close to the budget at $44,197,000, about $193,000 below budget. Operating expenses, however, came in $1.9 million below the budget at $40,732,000. That was driven largely by really low health and welfare costs in the month. That was below budget, about $1.2 million, and we had about a $600,000 favorable variance in our bad debt and provision for charity. We did have lower private pay, even though we were challenged with that government payer mix. So we ended up the month with a operating bottom line a little over $1.7 million above the budget at $3,465,000. Non-operating income for the month came in $83,000 above budget at $1,763,000, giving us a total bottom line from the GASB perspective a little over $1.8 million above the budget at $5,228,000. And I do want to point out that operating bottom line on a year-to-date basis, just $53,000 below the budget. You know, there's a lot of hard work that went on to make up that deficit, and the management of the hospital really, you know, when we put out the call, pitched in, and it's really being driven by lower costs because of the payer mix. We haven't been helped a lot with the revenue, so it's really been folks pitching in and really watching the store. So we'll take a quick run through the Financial Accounting Standards Board format. This is the way the financial markets might adjust our financials when they look at us. Operating bottom line doesn't change the same. It doesn't change at almost $3.5 million. We pull out our unrealized loss on investments and our tax revenue that supports our general obligation bond debt service to come up with non-operating income from a FASB perspective about $254,000 above the budget at $539,000 and a total bottom line, again, almost $2 million above budget at $4 million. So are there any questions on March?
As you said, it was good numbers. Thank you. We'll go on to hospital operations.
Yes, we're going to talk about the preliminary results for April, and they also have a good story to tell. Gross revenue for April came in above budget by $1.1 million, and it was higher than April a year ago. The inpatient gross revenue came in $1.3 million above budget at $131.2 million. The outpatient gross revenue came in below budget by $186,000. The major drivers of the favorable revenue variance were not necessarily the typical ones you expect to see. One of them is. But the first being patient days, they came in 6.4% above budget. And they drove the room and board revenue higher than we had budgeted. The increase in census also drove ancillary services volume and revenue higher. And this resulted in a favorable revenue budget variance of $2.1 million. The other thing that drove the favorable revenue variance was the cardiac cath lab, and that typically is a driver. And it came in 5 cases above budgets. Our key census statistics reflect a really long length of stay. And we believe, although there's more in-depth dive to be taken, that much of this was related to respiratory cases and cardiac cases. The average length of stay was 5.19. We had budgeted 4.90, and that seems like a small difference, but it's not. It was 10.7% higher than April a year ago. Our outpatient observation days were below budget at 65, and that's a 26.5% variance, and that's a favorable figure. Our average daily census of 174 was 11 cases above budget. The increase in the average daily census as I mentioned earlier, we believe was being partially driven by cardiac procedures and respiratory cases, and they typically have a longer length of stay. The admissions trend, 12 cases above budget. That's a minor variance of 1.2%. The patient days were 5,209 days above budget. Oh, no, I'm sorry. They came in at 5,209. We're above budget by 312. I'm sorry about that. But that is a significant variance. It's 6.4%. And that resulted in room and board revenue being booked at 2.7% above budget. The patient days for the month were 193. Surgical trend, it was down for this month, and in pretty much every category. The surgical cases came in 378 below budget by 49. That's 11.5% fewer than we had planned. It caused an unfavorable variance in surgical services revenue of approximately $2.6 million, or a 7.2% negative variance. The surgical cases were 22 below April a year ago. The inpatient surgeries were 30 below budget. The outpatient surgeries came in at 19 below budget. The general surgical cases were below budget by 38. Joint replacement cases were below budget by 6. Cardiac surgeries were below budget by 3. And the neurosurgical cases were below budget by 2. And I'll make an important point about that. Those are neurosurgical cases performed in the OR. And when we get to the cath lab, you'll see that there were some significant cases done there. Cath lab procedures for April were just 3 below budget. They came in at 379. The inpatient cath lab procedures were below budget by 7. The outpatient cath lab procedures were above budget by 4. Cardiac procedures were above budget by 5. PTCAs were above budget by 8. Neuro-IR procedures were above budget by 3. And these are the typical neurosurgical cases that would have appeared in the OR that are now being done in the cath lab, and they're major cases. Peripheral vascular procedures were below budget by 11. Non-vascular IR procedures were on budget at 66 procedures. But there was a shift from inpatient cases to outpatient. Deliveries for April came in below budget by 34. There were 42 deliveries fewer than a year ago at this time. Non-emergency outpatient visits came in below budget by 649. We had 6,728 visits. The infusion center visits were above budget by 100. They had 109 visits, and it's a 67.7% above budget figure. The prenatal diagnostic clinics came in 155 under because we haven't opened it yet. And that's one of the things that's driving these numbers. The opening's been pushed back due to delays in permitting by the city. And it's very important to us to get this open on time because of federal monies that are resting on us doing that. X-ray visits were below budget. OB visits were below budget. Respiratory therapy visits were below budget, and cardiac rehab visits were below budget. The emergency room had 15 more visits than we had budgeted. And this is also a part of the report that has enormous amount to do with coming up with reasonably acceptable numbers. Our non-productive FTEs came in below budget by 8.1%. But no, I'm sorry, 8.1 FTEs. The productive FTEs came in above budget by 23.8. The total FTEs of 1,464.6 were above budget by 15.7. And those things go somewhat along this last number with the extended length of stay and their staffing ratios that you have to meet. However, productive FTEs for adjusted occupied bed of 5.46 came in 4.2% below the budget, and therein lies some savings. The total FTEs per adjusted occupied bed of 6.23 was 4.9% below the budget. That's a lot of money. Other operational statistics, Surgery Center had 437 cases in April. They were 6.8% below their budget. Clinic visits for the month numbered 3,857, and they were below budget by 350. Washington Urgent Care down by 20. Newark Clinic down by 257. Our physician there is still on medical leave. Warm Springs down by 101. Ohlone down by 5. And the Nakamura Clinic down by 17. The preliminary payer mix information for the month of April showed an improvement over what we'd been experiencing. You might recall in the prior month, and in the past quarter, we'd been experiencing higher than budgeted government-sponsored payer mix. And in the last quarter, it had come out about 75.2%. This month, the government-sponsored patient revenue made up 71.7% of total gross revenue. You can roughly attribute about $1 million per percentage point to that number. So that has a lot to do with why the financial picture improved. The government programs for Medicare and Medicaid do not pay the cost of providing care. And the higher that number gets, the worse our financial performance. HMO revenue was 3.6% of gross revenue. We had budgeted 3.5, so slight improvement there. PPO revenue was 22.9% of gross revenue. We had budgeted 23.5%, but we had been as low as 20.8%, and so this was an improvement over the past quarter. Private pay revenue was 1.8% of gross revenue, and we had budgeted 2%. That's also a good variance to have. And finally, the days cash on hand for April was 159, up 5 days over the prior month. The days in accounts receivable were 57, which I think is a pretty good figure. And there was $530,704 in charity care applications pending or approved in April.
Nancy, any questions for Nancy? Great. Okay, thank you. We'll now move on to our action items, which will be presented by Dr. Stewart. Item A.
Mr. President, in accordance with district law, policies, and procedures, I move that the board authorize the chief executive officer to enter into the necessary contracts and proceed with the purchase of the ASCALP containers for a total amount not to exceed $32,566.04. Second.
We have a second from Director Wallace. Nancy?
This is new processing equipment for the sterile processing department, and they are to convert how we handle our ortho instrument trays, converting from wrap to rigid containers. Our current process is to wrap the trays and then stack them on top of each other. The new regulations that have come out state that we're no longer allowed to do that. The trays are not to be stacked. So this is something that is being driven in part by new regulations.
We're going to eliminate the wrap. More efficient. Good. Any discussion, questions? Dee, could you call the roll?
Director Nicholson?
Aye.
Director Stewart?
Aye.
Director Wallace?
Aye.
Director Danielson?
Aye.
Director Epen?
Aye.
Motion passes. Item B.
Mr. President, in accordance with district law, policies, and procedures, I move that the board authorize the chief executive officer to enter into the necessary contracts and proceed with the purchase of the cryostat equipment for a total amount not to exceed $32,072.
Thank you. Do we have a second?
Second.
Second from Director Wallace.
We're recommending that the board move forward with the purchase of a new cryostat. The current one is 13 years old, and it is past its useful life. If we don't have a functioning cryostat, we have to cancel surgeries.
Right. Great. Any questions? If none, Dee, could you call the roll?
Director Nicholson?
Aye.
Director Stewart?
Aye.
Director Wallace?
Aye.
Director Danielson?
Aye.
Director Epen?
Aye.
Motion passes. Item C.
Mr. President, in accordance with district law, policies, and procedures, I move that the board authorize the chief executive officer to enter into the necessary contracts and proceed with the purchase of Stryker System 7 drills and related accessories for a total amount not to exceed $485,756.
Do we have a second?
Second.
Second from Director Wallace. Nancy, these are expensive drills.
Yes, we own 11 Stryker 6 drills, Model 6, I guess. 7 each that were purchased in 2009, 2 each purchased in 2011, and 2 each purchased in 2012. Due to the constant use and need for updated technology, we will be trading in old drills when we purchase the new. The cost of the equipment is $485,756, including tax, and a $30 trade-in credit. This was in our capital budget for this year. These are instruments used in orthopedic and some open heart surgery procedures.
It's a $30,000 trade-in credit.
Mm-hmm.
Yeah.
Yeah. Yes.
I guess we take any trade-in.
Yeah, they're still expensive as a trade-in. Any discussion? If not, Dee, call the roll, please.
Director Nicholson?
Aye.
Director Stewart?
Aye.
Director Wallace?
Aye.
Director Danielson?
Aye.
Director Epen?
Aye. Motion passes. Item D.
Mr. President, in accordance with district law, policies, and procedures, I move that the board authorize the chief executive officer to enter into the necessary contracts and proceed with the purchase of a Hologic Mini C-arm for a total amount not to exceed $66,642.50.
Thank you. Do we have a second?
Second.
Second from Director Wallace. Nancy?
Okay, the one we have is 13 years old,
Mm-hmm.
and its image detail has deteriorated over time. It has a very small monitor, which makes it hard to see the images during surgery. The purchase of a new mini C-arm will give the orthopedic surgeons much needed clarity, and it comes with a 24-inch high-resolution monitor. And it's labor saving. It does not require a technologist to operate it.
Great. Even better. Better pictures. Okay. Any discussion, questions? If not, Dee, call the roll, please.
Director Nicholson?
Aye.
Director Stewart?
Aye.
Director Wallace?
Aye.
Director Danielson?
Aye.
Director Epen?
Aye. Motion passes. Item E.
Mr. President, in accordance with district law, policies, and procedures, I move that the board authorize the chief executive officer to enter into the necessary contracts and proceed with the purchase of 4 Blanketrol 3 units for a total amount not to exceed $34,542.
Thank you.
Second.
We have a second from Director Wallace. Nancy, these are a little older than 13 years.
Yeah, these are more than 13 years old. They're between 18 and 22 years old. They do heating and cooling of patients. The equipment's no longer supported by the manufacturer and is becoming unreliable. It's time.
Yeah, I agree. Any other discussion, questions? If not, Dee, call the rolls, please.
Director Nicholson?
Aye.
Director Stewart?
Aye.
Director Wallace?
Aye.
Director Danielson?
Aye.
Director Epen?
Aye.
Thank you. Motion passes. Item F.
Mr. President, in accordance with district law, policies, and procedures, I move that the board authorize the chief executive officer to proceed with the purchase of DirecTV off-air head-end and distribution equipment to upgrade the hospital's digital television satellite system for a total not to exceed $164,085.21.
Thank you. We have a second from Director Wallace. Nancy, switching providers.
Yes. At your meeting on May 11th, 2016, you approved the purchase of 130 digital-ready televisions for house-wide upgrade in all patient rooms. The replacement LED flat-screen televisions are energy efficient and require less space. They're also compatible with future IT technology and applications. In order to complete the transition from analog to digital cable television, we're recommending discontinuing our Comcast digital cable subscription and upgrading the digital television satellite system with a DirecTV off-air head end and distribution equipment. The head end and distribution equipment is necessary equipment to receive, process, and channelize all of the programming media from various sources in one location. This equipment will allow the hospital to act as its own cable television service and prepare the television signal for distribution to each television within the campus. The upgrade will improve the quality of television picture and also improve, we hope, the reliability of the system.
Thank you. Any questions or discussion? If not, Dee, please call the roll.
Director Nicholson?
Aye.
Director Stewart?
Aye.
Director Wallace?
Aye.
Director Danielson?
Aye.
Director Epen?
Aye.
Thank you. At this point in time, we're going to adjourn to a closed session. We're going to reconvene the meeting to open session, announce that no reportable action was taken in the closed session, and there being no further business before this board tonight, this meeting is adjourned.